Good morning, everyone. This meeting of the Healthcare Affordability Advisory Committee will now come to order. Please note that this meeting is being recorded. I'll now ask for a roll call.
Good morning. Joan Allen.
Present.
Barry Arbuckle.
Present.
Eliza Arjoyan. Katie Bassler.
Present.
Stephanie Klein.
Present.
Carmen Comsty.
Present.
Adam Daughtery. Iftikhar Hussain. And for our new members, just a reminder for the record, go ahead and press the button so that the light turns green. And you could say present.
This is Iftikhar. Present.
Wonderful. Thank you. Hector Flores.
Present.
Stacy Hiratas.
Present.
David Joyner.
Present.
Travis Lakey.
Present.
Tam Ma. Carolyn Nava.
Present.
Mike O'Day.
Present.
Janice O'Malley. Mario Riazza.
Thank you. Present.
Thank you. Sumana Reddy.
Present.
Amanda McAllister Wallner.
Present.
Thank you. Christina Rodriguez.
Present.
Karen Savage Sangwan. And for the record, you are present. Sorry, I don't think I got it in the mic. Yeah, I just didn't. Okay, sorry, I got to get it in the mic for the virtual. Yep, you're good. Andrew C.
Present.
Stephen Shortell.
Present.
Thank you. Sarah Sorokin.
Present.
Thank you. Ken Stewart.
Present.
Suzanne Usage.
Present.
Renee Williams. Michael Weiss.
Present.
Thank you. Manan Shah.
Present.
All right. Thank you.
Thank you, Jane. We now have a record of who's in attendance. I'd like to introduce our attending board member who is observing the meeting today. The board member is Richard Pan, who is with us today online. He will listen in to the presentation. He will listen to the presentations and discussions and help convey your input to the Healthcare Affordability Board. Others here to assist are John Paul Buchanan, a member of the HCI legal team, and our co-facilitator, Jane Harrington from LRI. So on to today's agenda. After the executive updates provided by me, CJ Howard and I will facilitate a discussion on data submission enforcement. The committee will break for lunch around noon, and upon our return, CJ and I will transition to an introduction on spending target enforcement, specifically related to its timeline and considerations for enforcement. Lastly, Margareta and Debbie will end this meeting today by providing the committee with an update on behavioral health spending, including the definition and the measurement methodology, and a summary of public comments we've received so far. So I'll move on to executive updates. So before I start the executive updates, I want to welcome 4 new members of the advisory committee. Manan Shah, Iftikhar Hussain, Amanda McAllister-Wallner, and Michael Weiss. And a thank you for those who were reappointed and continue to serve on this committee. I would like to allow the new members a minute each to introduce themselves and tell us why they chose to serve on the committee. Let's start with Manan, then Iftikhar, Amanda, and then Michael.
Hi, good morning, everyone. My name is Manan Shah. I serve as a general manager at Anthem Blue Cross. In that role, I oversee our Affordable Care Act business, which includes Covered California and our small business employers across the state. I'm excited to be a part of this committee. I appreciate the opportunity to work with each of you. I think that we have a real opportunity to impact healthcare in California, and I appreciate being a part of it. Thank you.
All right. Good morning. My name is Iftikhar Hussain. Really happy to be part of this group and contribute in any way I can. I've been with the city and county of San Francisco for the last 3 years as an employer. And then just recently, I moved back into the provider side. So I am the CFO at Salinas Valley Health. I hope that my input, my goal really is to use the community impact as a compass in comments and the goals for this group. And yeah, look forward to today's meeting as well as future meetings. Thank you.
Hi. Hi, good morning all. My name is Amanda McAllister-Wallner. I use she, her, hers pronouns. I'm the executive director at Health Access California, which is the statewide health consumer advocacy coalition. Been working for nearly 40 years to achieve quality, affordable, and equitable healthcare for all Californians, including working to remove barriers to accessing healthcare based on immigration status, as well as being supporters of the creation of the Office of Healthcare Affordability. Very excited to be here, excited for the work that the board is doing and the office is doing around healthcare costs, especially at a time when so many Californians are struggling with the high cost of living. And I've been with Health Access for 9 years. I started working with Health Access as the director of our California LGBTQ Health and Human Services Network, so also have expertise in queer and trans health as well.
Good morning. I'm Mike Weiss. I'm a general pediatrician. I practiced in the community for about 22 years, and I've been the Vice President of Population Health at Children's Hospital of Orange County for the last 11 years. Delighted to be here as an advocate for children, as well as an advocate for value in the care that we provide. So I'm really looking forward to learning from you all and contributing.
Thank you all. Now I'll provide some information about the Rural Health Transformation Program. So at OCA's July board meeting, we discussed an overview of the federal budget reconciliation bill, H.R. 1, which makes nearly $1 trillion in federal cuts to the Medicaid program over the next decade. H.R. 1 also includes the Rural Health Transformation Program, administered by CMS, which provides $50 billion over 5 years to strengthen healthcare access in rural areas. Next slide. Out of the $50 billion, $25 billion will be distributed equally among states with an approved application. For the remaining $25 billion, CMS has more flexibility. The law requires CMS to consider certain factors when distributing these funds, such as the state's share of population that lives in a rural part of a metropolitan area, its share of rural health facilities compared to the nation, and the situation of hospitals that serve a disproportionate number of low-income patients with special needs. Next slide. Each state is required to submit a detailed rural health transformation proposal to CMS. CMS released guidance on September 15th. Applications are It's a very accelerated timeline, or due November 5th. CMS will approve or deny applications by December 31st of this year. To receive funding, states must submit a rural health transformation proposal that addresses the following goals. They're listed here on the slide. Make rural America healthy again, sustainable access, workforce development, innovative care, and tech innovation. Next slide. So each of these previous goals must be supported by at least 3 of the activities listed here. Some of these include promoting evidence-based interventions to improve prevention of chronic disease, or improve prevention or chronic disease management, providing payments to healthcare providers. There's some focus on workforce retention efforts, right-sizing healthcare delivery by identifying needs, needed services, facilities, et cetera, and projects that support value-based care, as an example. Next slide. So in California, in HCI's office, State Office of Rural Health is leading the development of the proposal, guided by input from rural health leaders and feedback gathered through broad stakeholder engagement. These stakeholder engagement opportunities included a webinar on September 4th, along with a survey released after the webinar from September 5th through the 16th to ensure stakeholder feedback is captured, especially from rural communities. This input will be synthesized and integrated into priorities of the Rural Health Transformation Program proposal. HCI will also offer stakeholder listening sessions from September 29th through October 6th to review the priorities and strategy of the proposal. Next slide. So we have a mailing list that interested parties can sign up for. As I mentioned, it is a very accelerated timeline. So California is actively working on its application and seeking any feedback and input on the priorities we should highlight in the proposal. So I want to just pause here briefly if anyone has any questions about this proposal before I go on to other items.
Sorry. Go ahead.
Not a question, but a sort of overarching comment. I've been tracking the Rural Health Transformation Program closely on the federal side, and it would be very easy for a state to implement it in such a way that most of the money never actually touched the rural community, where the money instead went to technology consultants more broadly, driving consolidation with non-rural providers, buying up rural providers. There is a way to spend that entire $50 billion and have none of it go to rural healthcare and none of it go to rural residents. And so as California is working on its application, recognizing that in this climate we will have to craft that application carefully, but would call on HCI to make sure that money is going to people and communities in rural places. To me, that leads us toward the workforce bucket, leads us toward being careful about some of the language that on the natural would lead to consolidation. And also within the technology space, recognizing that there are technologies where the only savings and benefit that they create is to replace labor with technology. And then there are other technology solutions that allow communities and providers and workers to do their job better and to focus on technology solutions that lead to expanded services rather than just supplanting labor with technology.
Thank you, Stephen.
Yeah, building on Joan's comment about workforce development, just a point of information. At Berkeley, we have an online MPH program and a whole cohort specialization in rural healthcare. And if there isn't that connection already made, it may have been already made. It could be helpful in the application. And about half of these students are from California. Some of them are across the nation as well. And this is through a donor lived in rural California and gave us a bunch of money to start this program. And so I just want to make sure everybody or the relevant people writing the application are aware of that, because it speaks to workforce development in rural areas. And some of the people, I think, are people you probably know that are getting this degree and then working particularly on the policy front in their local communities as well, to make sure the money that Joan talks about does get to help the people in rural areas.
Steve, what was the name of the program or the degree?
Yeah, it's the online, we call it the OOMF program. It's online, on-campus MPH degree program, and it's the Rural Health Leadership Initiative. And the person to contact is Deborah Barnett. She'll tell you all about it. You can also Google it and see who's there. And there have been interviews with some of the rural health leaders already on some of the things they're doing in their states to advance rural health care.
Others?
I had a comment. So a comment and then questions. So the 50 billion is great, but I think it's important to keep in mind how much this is in relationship to the reductions in HR1. So it's a $1 trillion reduction in HR1. The HR1 cuts are permanent and ongoing. The Rural Healthcare Transformation Fund is one time and expires after 5 years. So, and I think furthermore, you can see that it's divided evenly among states, which would really hurt California. So even though, whatever we get out of this would be great, it's better than not having it. And I really applaud this group for putting thought and effort into allocating the funds and getting the funds for us. But it does not, my point is the impact of the community of HR1, this will not put a big dent in it. So we still need to be creative about what we need to do to maintain access and health in the community as a result of HR1. My question is the application criteria and standards that we're setting. At what point do we get a draft of what we are proposing to the government, to CMS?
Thanks. So I'll have our colleague from our Workforce Development Division come up and answer that question. And introduce yourself, Hovik.
Yeah. Hey, everyone. Hovik Kosrovian, HKI Workforce Development Senior Policy Advisor, leading the team on the proposal. So because of the condensed timeline, the listening sessions are going to be the main area where we talk about the priorities, like the planning of what we're going to do within each of those goals and the potential activities. Because it's such a condensed timeline, it's due on the 5th. We have we're looking to try to get it ready by mid-October. So most likely, if we're able to release it, it will be after the fact because it's such a condensed timeline. But one of the things we want to do is the entire process, including the listening sessions, which will be recorded and posted online, inviting everyone to attend those. They'll be very specific and targeted based on each goal. Those will be the opportunities to see what we're planning with the proposal, to see what activities we're going to do and the intent of it. Once CMS decides, because one of the difficult parts is we're applying for a maximum amount, and then CMS will come back to us and tell us the actual amount that we're eligible for, and we have to revise the entire thing. So we're applying for 200 million for each year for 5 years. They could potentially come back and say, oh, you're only getting this much, and then we got to change the entire planning, all the activities, the budget. So it could vastly change from what we initially have. So that one of the things we're going to try to do is once that's determined, then we'll kind of put out here's exactly what's going to include. We want to have that available only when we know for sure what CMS approved. We don't want to kind of say, oh, we're going to do all this and then end up we can only do half of that. So it's very challenging. So that's one of and our intent is to Once we know exactly what it is, then we'll put it up on our website and all the information will be available.
At what point does CMS tell the state?
Can you use the microphone?
At what point does CMS tell the state how much it's eligible for?
So the notice of funding opportunity requests that all states apply for the maximum 200 million.
Okay.
So once we submit that on November 5th, I don't know how long it'll take. I'm assuming it won't be, hopefully be quick. But within the next, I would think in the next few weeks, they'll come back to us after that and tell us, oh, based on the qualifying factors. And, feel free to read the notice of funding. It's about 124 pages. It's pretty intense. I don't recommend it, but just to tell you, there's about 20 factors that get involved to like that split of the 25 billion. Based on that, they'll come back and be like, oh, we saw your scores. We see where the state ranks. Here's where you're eligible for. So I would hope at some point or late November we'll know that, because they do have to make decisions by December 31st. CMS does. So yeah, there's no timeline on the actual like funding announcement, but we hope some point in November we'll know, because we'll have to really. Best case scenario, we don't have to revise anything. We'll get the full amount. Worst case scenario will be pretty significant reduction. We're hoping for at least a baseline, and then it'll be an adjustment. They haven't given a timeline.
Is this a question for? Okay, go ahead.
Thank you so much for sharing. My question is, do you know if the review process is going to be similar to past NOFO review processes? Are they using still some kind of committee? Just wondering if the process is the same and the criteria are going to be the same. Thanks.
They do have a review committee. The notice of funding opportunity outlines in pretty great detail how many points you're available for in each category, and that'll help them decide the funding. One of the things they're doing is every year the application will in a way get rescored when you get awarded, and depending on how you're doing, you'll get to continue receiving the money, or it'll potentially get lowered if you're not meeting their goals. It could also potentially go up if other states aren't spending all their money. They'll pull that and then give it to other states that are moving quicker. So it's not the best way, I would say, but it's a review committee, and then again the scores are being reassessed every year, which is kind of tricky. So you do have to keep meeting those standards and improving. They have to see improvement if you want to continue to get the funding each year.
I think I saw Amanda. You had your hand. Travis, it looked like you might want to say something, and then Carolyn. Was it to this topic? Okay, so we'll come back around to you. Is that all right? All right, go ahead, Amanda.
Thank you. So I would just be curious, how you can share updates with this body and others on the application process following. I know, as part of HR1, there are going to be a lot of future waivers and applications related to, our MCO taxes, our QAF, our work requirements. This is the first of many where we may get to see how the administration is responding to California's applications and requests. So how can we report back on what's learned through this process?
Yeah. For this rural health one, we're happy to, with Vishal and Elizabeth's leadership, to bring it back periodically with these meetings and give updates. We're planning on doing that with our Workforce Education and Training Council. So we're actually doing an update on our October 16th meeting, which actually will be further along, so we'll have a little bit more detail at that point. But we're going to do continually updates. We're happy to come back to this group and other OCA groups to give those updates as well. And I'll really want to plug our mailing list on our website for the CalSOAR. That's where you'll get those updates on when the listening sessions occur. Our website will post the information as we get it and when decisions are made and finalized and what we're going to plan on doing with the implementation. That'll all be on our website and through our mailing list if you sign up for the rural health track.
Travis and then Carmen.
First, I want to thank you for your work on this. I know this is a lot to go through and review and a tight timeline. I want to encourage as much of the funds to go back to rural hospitals as possible, because rural hospitals aren't doing great right now as it is. I mean, Glenn's closing, Southern Inyo's either closing or reducing services. It's not great out there now. I know we had a building project planned with HR1. I see as negative years 3, 4, 5 going forward. So now we don't know how we're meeting seismic going forward. So any of those funds that can get back to rural hospitals would be a godsend, because there's definitely more funds going out than coming back in.
Thank you, Carmen, and then Tam.
Thanks, Hovik. I think I had a very similar question to Amanda and Marielle on the, the potential changes of the conditions and who's approving, the funding that's coming through here. I guess, do we have a sense of what the committee makeup is that's going to be reviewing if the point system may change, and if problematic viewpoints about vaccines, gender affirming care, reproductive services, all the things that we are in California hoping to protect may be put onto this funding, and what potentially could we HCI kind of plan on doing to make sure that we're ensuring that if we're putting resources, federal resources, into rural care, that we can ensure that important pieces of our public health programs and are reaching rural communities.
Yeah, they haven't announced who the review committees are yet. And I don't know if they will. We've been in a couple of webinars and it's been asked and they haven't specified. As far as the other part, it's a little stressful to know that every year is going to get reassessed and scored. What we do know is those factors shouldn't change. Now, there's a lot of leeway in the HR1 about this fund, and the CMS administrator can kind of decide as they please if they think someone's not using the money appropriately and pull it back, give it to other states. So it could get very tricky. But we hope with federal grants, I know there are rules. Now, the way this bill is written, it gave them a lot of flexibility, and you can see that when you kind of read some of the details. But we hope they follow standard federal grant guidelines. But yeah, at this point, there's no guarantee on anything. We're trying to do the best we can with the proposal to ensure that we follow the guidelines of the notice of funding opportunity and not go astray of like other things, and be very specific on what it asks for and what we're going to do. But also to be cognizant of, there are things that we have to address, and we have to get creative in how we do that.
Thank you, Tam. And then I think we'll try and conclude the discussion on this item. Go ahead.
Sure, thank you. I just wanted to add on to the comments like Dr. Shortell had made about the rural training programs within the health professional schools at UC, and he talked about the MPH program at Berkeley, and I just wanted to mention that our schools of medicine do also have kind of rural tracks for their education programs to encouraging providers to train and encourage them to serve those areas. And I can follow up with information about that as well. And then second question is, I think in the notice of the funding opportunity, there was kind of reference to some specific priorities, federal policy priorities that they are encouraging states to adopt or embrace. And it seems like some of those would also require, if they were to be adopted in California, like some statutory changes as well. And so what's the department's thinking at this point about those kinds of issues and how you might be approaching them, if at all?
Yeah, so it is clear if you read the notice of funding, and there's actually, if you do want to read it at the very end as an appendix, that kind of is a quicker outline of what they want. There are very clear expectations that you'll get points if you make legislative changes within those 5 years for things like scope of practice, telehealth, flexibility on upskilling providers to allow them to do different kinds of practices. So it's challenging. It's 5 years to make that kind of change is pretty challenging. As far as HCI goes, we're working with the administration and the legislature to identify if there's anything that potentially they might be interested in. But again, it's not something that we're very going to specifically call out that we can do or not. It's going to take more conversations, and unfortunately, we have like a month to put it all together. So it's not very likely you're going to be able to put out legislation in a month. And even if you can, who knows how long that'll take. So our perspective is going to be we're going to use what we have now. And whereas we work through with the administration, is there anything potentially that's an option for us? But again, it'd be too difficult to tell right now. Oh yeah, we're definitely thinking of this. But it's clearly you actually get almost 20% of the points come from actual legislative changes that they want to see states make, which is very interesting because then you can clearly see someone has an intent to we want these changes made nationally.
Right. Yeah. No, and I think some of those policy changes will be a very different direction from where California has been. So.
Yeah. So we're being cautious.
Okay. Thank you, Carolyn. Did you just make a comment? Go ahead.
Thank you, Jane. I'm kind of combining all of these thoughts now. Originally, I was responding to Joan's comments about making sure that we're thinking about more than just possible money-saving factors, but we're really looking at helping to preserve jobs and real lives out there, because we sit in our counties now facing the closure of Glenn County Medical Center because CMS has decided they are 2 miles closer to the next hospital and they don't warrant the funding. So with the closure of Glenn County Hospital, we not only have the impact of emergency room services, because now our older adult population, our population with significant disabilities, will now travel by ambulance 35 to 40 miles because 32 miles is too close to keep the doors open. We are also additionally losing 150 jobs with this hospital closure. So we get it. We get the cuts. We get the changes. The challenge is are we really looking deeply enough at where these cuts and changes require to happen? We're replacing people with machines. We're replacing hospitals with nothing but additional costs. So I'm just setting a pulse here and bringing that into the conversation, because these are the little places that just nobody pays attention. Nobody cares because there's only 23,000 people in Glenn County. But those 23,000 people have jobs and lives and emergencies, and there will be loss of life resulting from a decision like this.
Thank you. That concludes discussion on this item. We'll return back to executive updates, but I do want to note for the record that we did have a committee member join virtually. Adam Daugherty, we see you on there. Good to have you. I'll turn it back over to Vishal.
Thank you. Next, I'd like to update the advisory committee in public that on June 6th, OCA issued a determination to conduct its first CMIR, looking at portions of a material change notice submitted by Covenant Care California regarding the transfer of skilled nursing facilities and assisted living facilities. So this includes assets, operations, and leases. The CMIR focuses on components of the transaction involving 3 Covenant Care skilled nursing facilities that will be operated by entities affiliated with the Ensign Group. After the transaction closes, the 3 facilities are listed here. OCA will publish the preliminary CMIR report on our website and allow 10 business days for parties and the public to submit written comments in response to the findings. Next slide. So I want to take a moment to review our quarterly work plan for the remainder of the year, and then I'll outline plans for the upcoming 2026 calendar year. So this shows the work ahead broken down by program area. At today's meeting, we'll discuss data submission enforcement, introduce a spending target enforcement considerations. We'll also provide an update on behavioral health spending definition and methodology, including summary of public comments. In October, we'll have a OCA Healthcare Affordability Board meeting where the board may vote, and this is tentative, on the scope and range of data submission penalties. They'll also discuss spending target enforcement, including a continuation of a discussion on how to assess performance of healthcare entities. If we're ready, we'll be able to provide an update on the Monterey Hospital Market Competition Study. We'll also provide updates on cost and market impact reviews. These 2 latter items will kind of depend on where we're at with the report. So it may happen in either October or November. In November, we will just have a board meeting where we'll again have a tentative vote on the scope and range of data submission penalties. So this is, this depends on how much we accomplish in October regarding whether the vote occurs. And then the board will also discuss spending target enforcement, including technical assistance and public testimony. We'll also be proposing revisions to the data submission guide regulations. So we'll be discussing that in November. And then an update on behavioral health spending definition, including a summary of public comments, as well as advisory committee feedback. And then in December, we again just have a board meeting where we'll still have we still have a placeholder for this tentative vote on data submission penalties. The board will continue discussing spending target enforcement, including TA or technical assistance and public testimony. And then we'll provide an update on OCA's work on hospital spending measurement. Next slide. So these are topics beyond December. For total healthcare expenditures and the spending target, we'll discuss the actual draft regulations for data submission enforcement. For spending target enforcement, we'll continue to discuss public testimony, performance improvement plans, and financial penalties. We'll follow up on high-cost hospitals and factors OCA uses to identify high-cost hospitals. Moving on to the promoting high-value system performance workstream. As you may recall, we delayed a vote on setting a behavioral health investment benchmark. We'll follow up on this item and discuss any progress we've made since then. And then for assessing market consolidation, we'll provide updates on any material change notices received and any timing of reviews for notices and CMIRs. Next slide. So this is our calendar for the 2026 calendar Healthcare Affordability Board and Advisory Committee meetings. They're posted online on HCI's public meeting page. And then one more update that's not listed on a slide. I do want to let the advisory committee and public know that AB 1415 passed the California legislature. So this was legislation that would include new notice requirements on private equity groups, hedge funds, and management services organizations to file notices of material change to OCA, and new authority for OCA to collect data and information on management services organizations. So that's awaiting a decision by the governor. And then lastly, as we do at every meeting, this is our slide formatting key. We use a blue arrow to indicate items that the advisory committee provides input or recommendations on based on statute and other areas requested by the board or OCA. And I'll now turn it back to Jane to facilitate discussion and any public comment.
Go ahead.
I just wanted to note in the minutes for the June meeting, I'm listed as absent, but I was present. I was a little late.
Thank you. Well, we will correct that. Any other discussion? Amanda?
Yeah, thank you. Michelle, could you talk a little bit more about what you mean by follow-up on high-cost hospitals and factors considered in identification?
Sure. When the board passed its motion in April of this year to adopt the sector targets, in the resolution it included language for OCA to provide annual updates on the factors it uses to identify high-cost hospitals. So the factors we used were the unit prices and the relative prices to identify those outliers. So the board wanted a refresh every year, kind of doing that 5-year look back that we did. 2023 HCI hospital financial data will be released soon, so we'll have another year of data, and then we'll be presenting to the board sometime later this year or early next year a refreshed set of hospitals.
Thank you.
Thank you. Other discussion from the committee? Go ahead, Joan.
Once you're done with the Covenant Care, CMIR. 'Cause I see sort of there's some CMIR in the future work plans, but it would be helpful, whether it's here or at a board meeting, to have a really thoughtful after action discussion of what worked in that process of doing that first CMIR and what where more information would have been useful to the team, because that's one where I believe that AB 1415 actually makes a difference, that we only got information from one side of the transaction, not the other, because of the that private equity acquisition. And so and then more broadly, how did that process go? And are there ways that that we can learn from that initial process? So actually doing like, and I don't know where, that may be more appropriate at a board meeting, but just getting that full after action.
Thank you. Are there any discussion from the committee on the executive updates? Hooray. Seeing none, we will now move to public comment. We'll recognize members of the public for comment on this particular agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access, we will alternate between members of the public present in this room and those attending virtually. Those in the room may line up at the podium. Those attending virtually may click their hand and we will unmute you on our end. If you're dialing in, you can press *5. During the public comment period, you will be unmuted. We will invite you to provide written comment also, if you would like, at the email posted on today's agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the committee is committed to communication and transparency, members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the comment period that is not included on the meeting agenda, except to place it on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Good morning. Jenny Nguyen with the California Hospital Association. We appreciate you highlighting the Rural Health Transformation Program, and we're glad to have the opportunity to engage with HCI in the development of the state's application. Even before HR 1, many of our rural hospitals are financially strained, and while the funding for the program will not fully address the devastating impacts to patients and providers from HR 1, we are glad for the funding opportunity. We urge HCI to prioritize sustaining access to care in rural communities, supporting a strengthened rural healthcare workforce, and bolstering rural healthcare providers' capacity in IT infrastructure. Thank you.
Thank you. Looking virtually, Sean Kim, we see your hand raised. We'll unmute on our end. You can unmute on yours.
Hello, can you hear me?
We can. Go ahead.
Good morning. My name is Sean Kim from California Pharmacists Association. CPHA represents over thousands of pharmacists, intern pharmacists, and pharmacy technicians across every practice settings in California. Thank you for the opportunity to provide California's RHTP program, critical issues, sustainable access to the care in rural communities. One of the most powerful yet underutilized solutions to bridge healthcare desert gap in the integration of community-based pharmacies into the state's healthcare infrastructures. Pharmacies are often the most accessible and trusted point of care. More than 90% of Americans live within 5 miles of one, and pharmacists constantly rank among the most trusted healthcare professional. In many rural and underserved areas, the local pharmacy is the only healthcare resource available. California pharmacists already have the legal authority to provide essential clinical care services from immunization, travel meds, smoking cessation, hormonal contraception, and naloxone access to HIV, PrEP, and PrEP, chronic disease management. During the COVID-19 pandemic, pharmacists administered over 90% of vaccination nationwide, ensuring they can close the gaps and deliver care at scale. Beyond vaccines, medication therapy management has been shown to return up to $1.67 for every dollar invested. Pharmacy's role extends further into behavioral health, opioid response, and community health worker CHW models. California has opportunity to make pharmacy a cornerstone of rural transformation, bridging preventive, accessible, and cost-effective care directly to the communities that needs it most. Thank you so much for letting me comment this morning.
Thank you. Looking back to the podium, seeing no one at the podium, looking virtually, seeing no hands raised. Noting for the record, we have about 93 virtual attendees. We will now move to, that concludes public comment on this item. We'll now move to our agenda item number 3, discussion of data submission enforcement, and I will turn it over to Assistant Deputy Director CJ Howard.
Good morning. My name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets Branch. We'll start with an update, or first discussion rather, for this group on the data submission enforcement process that we outlined. We discussed this with the board in July and again in August with updates based off of the July input from the board. I'll attempt to call out where there are differences or updates to the proposed enforcement mechanisms from July to August. Go to the next slide. We've included on this slide the statutory requirements related to penalties. Under the top portion of the table, we see that the board approves the scope and range of data submission penalties, or penalties writ large, as well as the penalty justification factors for assessing penalties. Under the bottom section of the table, we see the list of considerations under the scope and range and a list of justifications for the penalties. Next slide. Here is some information on data submission to date. We will update this once the 2025 data submission process concludes. So OCA in 2024 received all files from the 17 required submitters. On average, plans resubmitted each file about 2 times before OCA accepted all the plans files as complete and accurate. 13 plans had submitted all files by October 1, 16 of the plans had submitted by November 1st, and all plans by December 18th. OCA, for the data that is going to be required in 2025, OCA will require 2 new files. There's an alternative payment model and a primary care file. Medi-Cal managed care organizations will submit APM and primary care files, and OCA will continue to use total medical expense data from DHCS for managed care organization reporting. Combined with the addition of MCO submissions, plans will submit data by a licensed entity, which will expand the number of submitters from 17 to 51. For 2024, submission was at the parent level of the organization. In 2026, OCA may add a behavioral health file to data submission, and other requirements may be added or existing requirements may be amended based on the entity, which will expand the number of submitters from 17 to 51. For 2024, submission was at the parent level of the organization. In 2026, OCA may add a behavioral health file to data submission, and other requirements may be added or existing requirements may be amended based off of lessons learned from the 2025 process. So the board will approve scope and range. That, in other words, those are the penalty amounts and the penalty structure. So it could be per day, per member, a combination of both, fixed rate, etc. The board will approve the penalty justification factors. These guide OCA in determining which board-approved penalty amounts are assessed. The following factors are outlined in statute: the nature, number, and gravity of offenses, the fiscal condition of the healthcare entity, including revenues, reserves, profits, assets of the entity, as well as any affiliates, subsidiaries, or other entities that control, govern, or are financially responsible for the entity, or are subject to the control, governance, or financial control of the entity, and the market impact of the entity. Other factors can be considered, such as the entity's cooperation and active communication with the office. Next slide. The data submission guide defines standards for data completeness and defines data as acceptable when it is passed automated and manual data validation checks to ensure that the data are in a valid file format and layout, free of illogical or missing incomplete data values, and free of other technical deficiencies related to file submission, storage, or processing. The data submission guide provides a 5-day cure period for entities to correct any issues identified by the office after they are noticed. During this period, the office could delay the assessment of a penalty. So here we have considerations for the penalty structure. The penalty needs to be reasonable, provide an incentive to submit data timely, and deter entities from not submitting or withholding data to evade spending target enforcement. OCA is unable to measure total healthcare expense or enforce the target against entities that fail or refuse to submit data. If an entity fails to submit data, it may also impact reporting or spending for other healthcare entities, such as provider organizations that are measured based on attribution of total medical expense. Next slide. Now we'll turn to the proposed data submission and enforcement process that incorporates feedback from the board's July discussion. There were not any significant changes to these first steps in the process, but the data submission due date is September 1, and the office proposes that submitters would have 2 optional extensions that they can request. Each is 15 days, meaning submitters could request all of September as extra time to submit if they need to. The first extension would automatically be granted, and the second one would be authorized if the submitters complied with the requirements of the first extension, or in other words, submitted the required progress updates. Next slide. So next we have the first tier of data submission penalties. These are the untimely data submission penalty, and this is where we have made an update based on board input. If the data has not been submitted by the submission deadline or end of one or both extension periods, submitters would be subject to an initial flat untimely data submission penalty of $10,000. Then, and this is part of the update, if data are not submitted by November 1, the submitter would be subject to an additional flat untimely data submission penalty of $10,000 and a progressive enforcement process, which may result in a failure to submit data penalty. So the change here is an additional flat untimely data submission penalty, which would increase the submitter's total penalty at this stage from $10,000 to $20,000. Along with this additional penalty, November 1 starts a progressive enforcement process, which would include technical assistance, optional step of public testimony. If the data are still not submitted within 30 days of November 1, the submitter would be required to submit a data submission plan to submit their data no later than December 31st or date agreed upon by the office. Next slide. If data has not been submitted by December 31st or the agreed upon date, we get into the second tier of data submission penalties, the failure to submit data penalty. For data submitters that repeatedly fail to submit data, each year the failure to submit data penalty would double from $5 as an example to $10 in the second year, $20 in the third, $40 in the fourth, and so forth. The increasing amounts are part of the updates based on input from the July board meeting. OCA would make all penalties public once formally assessed. OCA also proposes that it could adjust the penalty amounts based on changes to an economic indicator. This is still an area of discussion, but one potential indicator would be the California Consumer Price Index. And last, OCA could continue to pursue other legal remedies in addition to the penalties to acquire the submitter's data. The office could take administrative action and could notify the licensing or regulatory agency of the entity's failure to comply with California law. Next slide. This slide shows a visual representation of what that process for a submitter who requests both extensions. We updated this visual to include what are now 2 potential untimely data submission penalties. So if the data are not submitted by October 1 after the 2 extensions, the submitter would face one $10,000 penalty. If the data are still not submitted by November 1, they would face the additional $10,000 penalty, or a total of $20,000. This is also where the progressive enforcement begins, which includes technical assistance and the option of public testimony. Again, still an area of discussion. If data is not submitted by December 1st, submitters would have to submit a data submission plan and submit the data by December 31st or mutually agreed upon date. If the data are not submitted by December 31st or mutually agreed upon date, submitters would face the failure to submit data penalty and both of the untimely data submission penalties. So that would be cumulative. Next slide. Here we see the same process, but for a submitter who did not request the 2 optional extensions, that just moves their first untimely data submission penalty up to September 1. The other steps in the enforcement process are the same. Next slide. This is just an illustrative example meant to guide discussion, showing how penalties could scale based on a submitter's size and potential dollar amounts. So now we're hoping to get some feedback on the office's current proposal to establish 2 flat untimely data submission penalties of $10,000 each, establish a $5 per member penalty for failure to submit data, double the per member failure to submit data penalty in each subsequent non-compliant year, and adjust the penalty amounts based on changes to an economic indicator.
All right, we'll open it up to discussion from the committee. We'll start down here. Thank you.
So this isn't my wheelhouse at all, but I just thought of an idea I thought I might as well throw out there. What sort of investment would it take to fund like regulatory staff or like OCA staff to do the work of compiling the data? Like, let's say a penalty is the entity has to fund a position that would be housed within OCA to collect the data and to get the data.
Oh, you mean like work within their systems?
Like if they're non-compliant with these regulations, like almost serve as a regulatory agency where you're then going in and getting the information.
So that probably wouldn't be the best way to do it, because the payers kind of know their own systems, and like an OCA staff or HCI staff couldn't just walk in and calculate the total medical expenses themselves. In addition to the penalties, if there's a failure to comply, we do have our legal team has the authority to take action for violating state law. So, we would pursue those other remedies first.
Thank you. Then we've got Stephen, Andrew, and then Kieran.
Yeah, I'm just curious, to what extent has this been an issue in other states with spending growth targets? Is this a big issue and problem, or not so much? And it probably decreases over time as everybody gets experience with the process.
Yeah, I can shed some light onto that. So I believe Oregon has imposed its first penalty for late data submission this year. I think what does set us apart from most of the other cost growth target states, obviously, is our enforcement teeth. And so noting that, that's why some of these penalties may seem large, given that it is, I think some people would look at this and say, well, it's just data submission, and it's not just data submission. It's also ensuring that we have the means and mechanisms to enforce our spending targets. And so that's why there's not a perfect analog for most other states. Oregon would be the closest one, given their enforcement scope and responsibilities. And again, they've had one issue, and pointed out, in our first year, so sample size of 1 for California, but by December we had full compliance from the entities that we had expected would submit data. Again, we're having compliance this year. I think we're moving along with all of the entities. We'll report back once this data submission process closes, and we've been able to fully report back on how many plans submitted and when they all submitted. But right now, it's not an issue. I think we're also just making sure that we're building towards the future when enforcement is looming.
Thank you. We've got Andrew, Kieran, Barry, and then Amanda.
Yeah, so I guess, CJ, if you can comment on quality of the initial submissions, right? So to me, data, whenever it comes, it's like a box of chocolates. You never know what you're going to get. But I mean, is it like pretty good the first time around, and you just have some fields that look a little funny, or I just trying to getting back to the whole compliance thing, right? We want to get the data. We don't really want to levy penalties. I think the penalties, they're pretty reasonable, I guess, given OCA's other enforcement mechanisms. But if you can just talk about data quality in general.
Yeah, I mean, I guess the one metric that I could point to that we reported on for the 2024 submission is that on average a plan had to resubmit twice, but that could have been for a myriad of reasons, from certain fields didn't add up across the files to there was some filing errors in the attestation file. So I mean, I don't want to paint with too broad a brush on this. I think that we got to a place where we thought that we were going to get pretty quickly with most payers or most submitters in the first year, and I'm happy to probably fill in that question more broadly the next time we meet based off of the 2025 submissions, given that we're going to have more than 17 plans submitting. We've got the 51 licensed entities that will be submitting, and I think I can probably shed more light on based off of our second experience.
Thank you. I've got Kieran, Barry, Amanda, and then Hector is attending virtually. Hector, I see your hand raised. We'll come around to you.
Thanks. This is helpful, and I appreciate you bringing it to us because obviously it's very important. There's nothing else the office can do without the data. So point well taken. I think I'm trying to understand how you came up with the penalty amounts and sort of comparing them to the potential incentive for an entity that has exceeded the cost growth, because they seem disproportionate. Like if my very smart colleague says the math is, you're charging a $5 per member penalty, but if a entity is at 4.5% cost growth, that's essentially $75 a member over the 3.5. So it would seem that an entity could very easily decide this penalty is the cost of doing business, and they're more incentivized not to submit the data and pay the penalty. So I'm just trying to understand how you arrived at these amounts and how you sort of contemplate, understanding, Vishal, point well taken, you have other legal remedies you can pursue down the line, but once we're 2 years down the line or whatever it is, we're getting far from enforcement. So just trying to understand, the penalties seem small to me and maybe insufficient to achieve the desired results. So if you could explain the numbers a little bit more, that would be helpful.
Sure. So, and part of that is, and we're conducting additional analysis and want to show these data once we're comfortable with the analysis that we're showing. And so we'll put the $5 or any amount in context of different metrics that you can think about of a plan from what their total healthcare expenditures are, which it'll look like a very small amount, noting that a high degree of total healthcare expenditures are direct medical expense that go to patient care. So you don't necessarily want to tax patient care. So we'll put that in context of what it could be as a percent of the plan's total net equity or their profits. And so I think once we have that analysis compiled, we'll, I think, can share that more broadly to inform your question.
Great. That sounds really helpful. Thank you.
Thank you. We've got Barry, Amanda, Hector, Joan, Stacy, and then Katie.
CJ, in the data that's been submitted by the health plans, is it clear to the OCA staff how much of the expenses are general administrative and profit for the health plan?
So we've done some analysis with that with the baseline report. I think we'll again be able to. We have a sample size of one where how we've collected our data. I think what'll be really illustrative for us too is this year for 2025 we collected the 2024 spend. In 2024, we collected 2023 and 2024. I think it'll be interesting for us to kind of assess quality and kind of figure out what the data actually were and what it revealed is looking at the 2023 spend as reported in 2024 compared with 2023 when it was reported in 2025. And I think we'll be able to get a better handle on your question. And then also, I think we're evaluating the way that we're measuring administrative costs and profits more broadly, and so.
And given that with the multi-state health plans, with money being fungible, trying to figure out, has profit been shifted to another state where they're not measuring profit? You probably can't answer that question right now. One more question, if I may. On the APMs that'll be submitted in 2025, are you having the health plans submit all the APMs that they offer, or just those that are HCP Land 3 and 4?
It's all APMs that they engage in, but the ones that count towards the APM adoption goal are the categories 3 and 4.
Okay, Amanda.
Thank you. I want to also thank you for just kind of the great overview of what this process looked like for last year, kind of what the planning looks like in some of these different scenarios and options. And I will similarly be interested to see the changes for 2025, given the large number of new entities that are required to do these submissions and what we learned from that. It's certainly encouraging that there was such good compliance and timely submission this year. But, I do think as we, see a like fourfold increase in the number of entities that, to see if that maintains. I also want to echo Kieran's comments. I think to me, I don't actually see this as like, oh, these are big numbers. I actually see this as like, oh, this is, maybe an inconsequential fine for some of these large entities, particularly for a part of, this process that's so, essential to being able to do the extra work. Everything comes out of, right? You can't get the total healthcare expenditures without the data submissions. We can't see if they're complying with the cost growth target without getting the data submissions. We're already looking at prior year spending, and then we're not getting that. We're not looking at like 2025 enforcement until 2026, 2027, right? So it's, we're already so backed up that having these long delays, and the timeline that you show us is like almost presupposing that there will be delays for a certain number of plans. So I look forward to kind of that contextualizing that you're talking about with some of these fees, because I do worry that especially the progressive fee schedule isn't really sufficient to motivate for some of these plans that maybe have a large incentive to not submit timely.
Thank you. We'll look virtually now. Hector Flores, go ahead.
Thank you. And Amanda asked my most important question. Thank you, Amanda. But I do have a question about, is there a plan to use the dollars that if fines actually are achieved, how does that money get used? Does it go back to help support OCA operations, or will it be held in some kind of escrow?
It wouldn't be for OCA's operations, but there's a healthcare affordability fund established in the statute where all penalty revenue is deposited, and then those revenues are intended to defray the cost of care for consumers.
Thank you.
Thank you, Joan, then Stacy, then Katie.
Two technical questions.
We'll go to Joan and then Stacy and then Katie.
So two technical questions in terms of the penalty structure, because thinking to Kieran's point about if an entity sees a big miss coming, that they may have a real incentive to just take the fine as the cost of doing business. If, for example, an entity is going to have a really big miss that they see coming in 2027, and they'd be facing that $5 per member fine, would they then be facing, if they then just don't submit that data in the next year either, would they be fined again at that $10 level? Or is the fine a one-time fine? Or is it like if I'm facing a late fee and that late fee may keep compounding just for that one miss?
I think it's a good question. I don't know that we've thought about that exact scenario, but off the cuff, I would imagine that would be non-submission 2 years in a row until because you would not have been compliant with the data submission requirements twice.
Great. That is a really helpful start, because that sort of leads into my second question, which is if an entity doesn't submit their data in 2027, faces the fines, faces the penalties, says, okay, you got me, submits it in 2028, would OCA have the ability to look back and perform its enforcement activities?
Yeah, I don't see anything that would kind of waive the entity. They were supposed to follow the law all along. So if there's a delay in getting the data to us, we'll pursue all remedies. But, once we get the data, we would act on it.
that's really, those two interacting is really helpful because it means that an entity basically can't escape justice forever so long as those fines keep doubling each year for that one failure to submit their 2027 data. We will eventually make it so expensive for them that they have to comply. Hate the lag time on that, but it's much better than, well, you can just pay $5 per member and get out of enforcement for that year entirely. So appreciate thinking about the interaction of those two.
Yeah, and I'll also point out, I mean, just as we're thinking about this, right, we'll have, like this year, the second year where we've had broad compliance. So that helps, I think. It makes it hard to make an argument that I can't submit data in the fourth year if you did it for 3 years when there perhaps weren't looming enforcement penalties. So I'll say that. And then also, this is a regulatory process. We can always revisit rulemaking processes if we start to see that this is not a strong enough, isn't compelling.
Yeah, really appreciate that. Just trying to think through how we get out of that cost of doing business box that so many regulations face.
Thank you. We'll go to Stacy and then Katie and then Suzanne.
Just a quick question on the $5 per member penalty. How are you equating a member on a PPO product? Are you attributing it or what's the process?
So when we say member, it's their enrolled population as reported to DMHC or CDI. So there's enrollment numbers that are typically like as of December 31st of this year, we had this many members. So that would be kind of the total member count from those figures reported to regulators.
So that's just for the HMO product?
No, for PPOs, there's a member, depending on how the plan's licensed, they're either at DMHC or CDI. So they have a total member count. Yeah, am I understanding your question correctly?
Yeah. I thought PPOs were mostly per subscriber versus member, but if you have that data, that's great.
Okay.
Thank you.
Okay, I think you're right about that. There may be different terminology, but they do have a total kind of enrollee count.
Great. Thank you. Katie?
So building off of what Joan and Amanda and Kieran have stated regarding the fines, for me, I don't know what $10,000 is to some of these entities. And so it's difficult for me to weigh in on whether that's valuable or not. But what is to me is the idea of having, I think on step 6 of progressive, having public testimony to explain why they weren't compliant. So having that made public as to how far away they were from the target, and just having them explain why they didn't submit or why they didn't meet the target. And it is a considerable increase from that 17 to 51. I don't know how you're going to manage all that data, but I have so much faith in this in the staff. So, but I would really support some public comment and testimony from the entities that don't submit. Thank you.
Thank you, Suzanne, and then Ken.
I just want to echo a big thank you for the work and the updates to have the progressive part, because what I believe is that a penalty's there because it never gets paid, because if it does its job rather, then nobody actually hits the penalty. So, and these entities submitting to me, as I understand it, they're one piece of the healthcare affordability, because obviously there are other entities in the process that set prices or are pieces of it. So my
thought, and echoing some of what my fellow committee members have shared, is that the timeliness of it seems to be the most important. Quality is, of course, maybe even more important, but getting it to be able to establish the quality and understand it. So my thought, and I guess I'm kind of combining some of the thoughts as well from earlier, is that the progressive penalty looks correct since they're one piece of the process, but then the untimely data submission, those two $10,000 ones, because you already have the breakout of small, medium, large, very large, maybe the thought could be to consider 10, 50, 100, 250, something like that, because then that pushes more information earlier, because in the penalties, kind of similar to the progressive penalty, are payable or are felt a little more firmly based on what that entity could pay and what people have talked about, the cost of doing business. So I also appreciate my other committee members' thoughts, is that we just want the right data in really timely, and that was my only other thought, to be able to get it in more quickly, closer to the 10-1, excuse me, earlier dates, and allow some more discussion. If they, rush to get it in and it looks like there's some changes just so that they don't miss the deadline, then they only have those 30 days. I think you've built everything else really well. That was just my one thought.
Ken and then Michael.
Yeah, just one question about the submission of the data. Has any consideration been given to what if plans submit their data on a timely basis for part of their enrollment, but not the other? Are they late or not late?
Yeah, I think we would still regard that as being late, that it's not complete per the standards in the data submission guide and what would be required of an entity to submit.
All right, thanks. Another question is, if there's repeat tardiness, like in professional sports, there are penalty tiers that you hit for certain things. Would there be any type of ramp up to make this really a true deterrent for not playing any games and delays like has been suggested here? Because, we're talking billions of dollars out in the street. And like with some of the penalties that have been imposed on some of the health plans in the state, almost $1 billion in one case. And I haven't seen that much change in their behavior. Not mentioning any names.
Thank you. We'll go Michael and then David.
I don't have to answer that, do I? Okay, great. In the vast array of data that's being submitted by these entities, are there any quality and or safety data components that are submitted?
So Michael, most of this pertains to the spending data.
Right.
We do have a separate work stream on quality and equity measures, and what we're doing is leveraging existing data that the health plans submit to DMHC. There's other measure sets that are reported to OPA, or Office of Patient Advocate, which has since moved within HCI. And then hospitals will be reporting the hospital equity quality measures to HCI. So what we're essentially doing is leveraging existing data. So the health plans so far are not submitting additional quality data or safety data to HCI or to OCA specifically for our measurement.
Okay, just the new guy, sorry, but I'm looking at least in my mind superficially, health plan or physician organization A that may be meeting the requirements, but their quality is not where it should be. Health plan or POB is not meeting it, but their quality is fantastic. Just is that all factored? And I'm sorry if that's been talked about for 2 years.
Oh, no, it's still an ongoing discussion. So kind of the intent of as we're measuring spending performance, we want to look at the same time as at quality and equity performance. So we want to make sure that quality isn't going down at the expense of spending performance. So we'll be considering that as we measure and report.
Thank you. David?
Yeah, I've got a comment and a question. My comment is I agree with where Suzanne was heading. I think knowing that within the 50 or so entities submitting, you've got huge variation in size. To me, having a flat $10,000 doesn't really make sense. I would think about having some graded penalty that's more meaningful for very large entities. My question is, will you also make this public in the same way you're making public which provider organizations miss targets? I think that's the expectation. Will you do the same with respect to data submitters? Will you be making it public which have failed to submit accurate or timely?
Yeah, so that's still under consideration. This is all the purpose of these meetings we have is to get that feedback. So we have heard feedback about posting names online, bringing them to the board to make public comment. So we're weighing all those proposals and working with the board on that.
So my input would be, if you're going to be public about which organizations fail to meet the targets, it would be appropriate to make it public which organizations fail to submit data in completely or on time.
Thank you.
Thank you. Additional comments, questions from the committee? And looking virtually also, seeing no committee members' hands raised. Back to you, CJ.
All right. Yep, we have one more slide for discussion. Perhaps not as fun as the first one, but does the advisory committee have feedback on the enforcement process, specifically the timing and duration of extensions and the progressive enforcement steps? I know that we've already heard from some members about the progressive enforcement steps and I think a desire for public testimony, but if there's any other comments from the advisory committee, now's time.
Any additional comments or discussion on? Okay.
All right, go to the next slide. So the board will vote on the scope and range of penalties, the structure and amounts, and we're hoping to have that vote between October and December of this year. OCA will draft regulations and begin the regulation process. If feedback received during that process requires reconsideration of the scope and range of penalties, OCA would then return to the board for more discussion and a potential vote. Next slide. Here we see the full timeline. We're having this discussion today with the advisory committee, and we'll continue through October with to engage stakeholders. We're aiming for a board vote in October to December, and we'll discuss the regulations in January and February, submit them to OAL in March of 26, and we're aiming for an effective date of the regulations for April 2026, and then data is due September 1st, 2026.
All right. Any additional discussion, comments, questions from the committee before we go to public comment? All right. We will now take public comment on this particular agenda item. Please step to the podium or raise your hand. Please limit your comments to 2 minutes or less. We will go to the podium. Go ahead. Is the microphone light green? Yeah.
Hi. Oh, sorry. Hi. Are you guys awake? Thank you. I love this event. Thank you for having a public format. Just a comment to the room. There's a public dashboard called Sage. Everyone's kind of trying to figure out pricing and kind of what things cost, where they cost. I mean, you can't really see it from the insurance side, but on the system side, you can kind of ascertain what it looks like. On the rural market side, there was a comment on there. You can see what rural market margins are at. So it's Sage Transparency. If you guys are familiar with this website, it's free. There's good quality measures you could use as benchmarks. So I would maybe recommend to the room to check it out. And I'm here all day, so if anyone wants, if I made a break, I could show you how to check it out too. So Sage Transparency, it's from the Employers Forum of Indiana. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting for the record we have about 91 virtual attendees. Looking back to the room, seeing no one at the podium. That concludes this agenda item. Are we moving to lunch? All right, we will take our lunch just a little bit early. The time is now 11:31, so we will return at 12:30. All right, thank you. Good afternoon. We will now move to item 4, introduction to spending target enforcement timeline and enforcement considerations. I will hand it back to CJ Howard.
All right, good afternoon. Hope that you all enjoyed lunch. We are going to focus on enforcement considerations for the next few slides. As a reminder, we will discuss other parts of the spending target enforcement process like technical assistance, performance improvement plans, and more in future advisory committee meetings. Move to the next slide. This is a timeline of the advisory committee discussion as it pertains to enforcement. So today we'll be discussing and introducing assessing performance against the target and enforcement considerations. In January, our plan is to have a discussion on technical assistance and potentially public testimony. April, discussion on performance improvement plans. June, discussion of penalties. And then July, October, the regulatory and rulemaking process. Next slide. So I'll be going, providing a brief overview and just walking through some slides. Seeing how everybody can read these, I will not be reading them verbatim for your own sanity. But this slide shows what the board shall approve, the scope and range of administrative penalties, and what they shall discuss, namely performance improvement plans, and provide input on administrative penalties. To the next slide. This slide clarifies that enforcement considerations are under the office's authority, and today we are asking for feedback from the advisory committee and the public on what factors, or what we're calling enforcement considerations, should be weighed or considered when contextualizing spending and determining which entities progress through the enforcement steps. Next slide. Continuing the overview of the office's responsibilities with regard to notification and communication, the statute pertaining to the statute, and before any enforcement actions can take place, the office must first notify the healthcare entity that it has exceeded the healthcare cost target, give the healthcare entity not less than 45 days to respond and provide additional data. The office is also required to consult with DMHC, DHCS, or the insurance commissioner to ensure regulatory consistency in the application of its enforcement actions. Next slide. This slide describes how the office is required to provide an entity who exceeded the cost target with technical assistance prior to approving a performance improvement plan. The office is also required to publicly post the identity of a healthcare entity implementing a performance improvement plan and to transmit an approved performance improvement plan to the appropriate state regulator for that entity. Next slide. Optional, so there's also described in the statute an optional waiver of enforcement process related to changes in state or federal law for investments and initiatives to minimize future and costly care, such as increasing access to primary care and preventive services, or under extraordinary circumstances such as act of God or catastrophic event. The entity shall submit documentation or supporting evidence of the reasonable factors, anticipated costs, or extraordinary circumstances. I'll hand it over to Vishal.
So on this slide, this shows a projected outline of OCA's proposed enforcement process flow. So the steps shown here on the process map may occur at multiple points of the enforcement process and not exactly as shown here, but for illustrative purposes, we wanted you all to kind of get a sense of our process. Next slide. So for today's discussion, we want to focus on the 3 steps shown in the yellow box. The first step, step 2, as shown in the triangle, or what is that shape called? Like a diamond. Was the target met? And then step 3, OCA sends entities that miss the target a letter, and entities have 45 days to respond with additional data and information, and they have the this is their opportunity to provide OCA more context. In step 4, we have where OCA evaluates that information and assesses performance. And then here we're able to take the information we get and then also evaluate it alongside some of these, what we're calling enforcement considerations. And I'll get into a little more detail on what that means. And then, as I said previously, the fourth step helps OCA contextualize entities' spending and determine which entities receive which enforcement steps. And these steps may be happening concurrently. Next slide. So I want to give an overview of how enforcement considerations could work. OCA will first report entity-level spending growth to determine which entities exceeded the spending target. Under the law, if an entity exceeds a spending target, OCA will provide technical assistance to the entity. Enforcement considerations are factors, characteristics, spending attributes, or other circumstances that OCA could consider when determining which entities would proceed beyond technical assistance. So going beyond technical assistance, this could be compelling public testimony, undergoing a performance improvement plan, or levying financial penalties for a given performance year. These considerations will not change or modify an entity's reported performance or directly exempt or waive an entity from enforcement each year. These considerations will be explored for their validity with in-depth conversations with entities and supporting evidence that the entities provide to the office, and then the office evaluates that information. These considerations will likely not impact all entities uniformly, and in many cases cannot be forecasted and incorporated into the process and methodology to set spending targets. And this point will become a little more clear as we go over the enforcement considerations. If the office notices consistent effects across entities, the office would present that information to the board to inform prospective adjustments to spending targets. So when I say consistent effects, if we're noting kind of a systematic pattern that many entities are exceeding the target for this reason, this could be additional information that the board could consider in how it sets future targets. And then just going on to the next slide. So some of you may be tracking that we have a waiver process. I want to distinguish between what we're calling enforcement considerations on the left and then reasonable factors on the right. So enforcement considerations refers to factors that OCA can consider during progressive enforcement. This comes from a specific part of the statute which describes what the director shall consider during enforcement. They include these bullets listed here, each entity's contribution to cost growth in excess of the target, any actions by the entity that have eroded or are likely to erode access, quality, equity, or workforce stability, factors that contribute to spending in excess of the applicable target, and the extent to which each entity has control over the applicable components of its cost target. Reasonable factors, moving to the right-hand column, is from a specific part of the statute which describes an optional waiver process that OCA may establish. Reasons that would allow an entity to apply for a waiver as enumerated in the statute include reasonable factors outside the entity's control, such as changes in state or federal law, anticipated costs for investments and initiatives to minimize future costly care, such as primary care, services, or extraordinary circumstances, such as an act of God or catastrophic event. So we're distinguishing between these two terms, and we'll be focusing on enforcement considerations in the next set of slides. So going on to the next slide. So this shows what the process is for other states. At the March 2025 board meeting, we had leaders from the Massachusetts Health Policy Commission, and the Oregon Health Authority come and speak about their respective enforcement processes. And, Massachusetts has the list on the left of what they call regulatory factors, and then Oregon has a list as well, which they refer to as their reasonableness factors. Next slide. So this shows a list of potential enforcement considerations for OCA. This is the beginning of the conversation. We'll continue to refine this list. So in the forthcoming slides, we'll discuss how each could be used as an enforcement consideration. We're seeking your input today, as well as input from the public on what should be considered in the enforcement process.
So we'll take each of these one at a time and pause for discussion, because I think each one merits a pretty lengthy discussion and potential input from everybody. So just to kind of frame the conversation here, we're not just going to go through all of the considerations and then pause. We'll pause one at a time for discussion. So first we'll discuss population characteristics. As you know, OCA collects age and sex demographic data that allow it to factor the degree to which changes in spending may be driven by underlying changes in the age and sex composition of an entity's population. OCA could consider the extent to which an entity's population, age and sex distribution has changed year to year and contributed to changes in spending. Adjusting for changes in age and sex composition may not always show a lower percentage change in an entity's spending growth. OCA would still determine if an entity met the spending target using unadjusted data, but could use age and sex adjusted spending change to determine to what degree spending growth is the result of these demographic shifts. On the slide, we see a chart with both the unadjusted and age sex adjusted growth rates for submitters in the commercial market for spending from 2022 to 2023. The age sex adjustment did change the growth rate for 10 out of 13 shown, though, as noted already, did not always yield a lower value. So we can stop here for discussion from the advisory committee in terms of how any input that it has on how age and sex could be factored when evaluating spending performance against the target.
All right, Mario.
Thank you so much for presenting this. I know this is a lot of information to put together, so I appreciate the effort. And also the graphics, I appreciate the chart as well. I'm wondering for enforcement, I appreciate age and sex being factored, but is there going to be any incentive or any kind of opportunity to include racial and ethnic demographic information?
So that is something that is a very important issue, and we're trying to explore that with quality measures, or not just OCA, but various state departments, including DHCS, CalPERS, covered California, and the data on race and ethnicity completeness is in flux, and it's not where we want it to be today, and even once you get that data, then kind of what's the, you need to know the relationship between that and how it impacts spending or lack of spending for certain populations. So, that's not ready for, in a state where we want it to be able to be used for something like this.
Are you able to clarify, where you might be able to anticipate this kind of data for future consideration?
Yeah, we actually do have a work stream on equity adjustments where the team is really digging in on looking at data to see in our healthcare payments data to see if if we could geocode members in terms of which quartile of the Healthy Places Index they're in, and then take a look at all their utilization and spending, and then seeing kind of what is that relationship between spending and demographic characteristics. It's going to take some time for us to complete that analysis, but there is a part of our law that requires us to develop an equity adjustment to the extent that there's a reliable, valid methodology.
Okay, I appreciate that. And do you know how far along that initiative is? Or, I mean, I guess how long until we're able to incorporate that kind of data into these enforcement criteria?
Yeah, that's a good question. I wish we could move as fast as we can, but that analysis is going to take a bit more time. I don't have a concrete date to share, but it is something we do intend to follow up with the board and the advisory committee.
Okay, thank you. That's it for now.
Thanks. We've got Mike and then Hector and then Andrew. And
two questions. So first, do we have the same data on the Medi-Cal side in terms of the age and sex adjustment? And then is there any risk adjustment in terms of medical risk adjustment also?
For Medi-Cal, so Medi-Cal managed care organizations for the first 2 years of our program have not been required to directly submit data to us. We've been using existing files or existing data reported to DHCS. So we are able to calculate total medical expenses using the medical loss ratio data that MCOs submit. That data doesn't allow us to do the age and sex adjustment for MCOs. In the future, they could be required to directly submit to us, so we could do that then. And then going back to risk adjustment, so some of the early work during the first 2 years, we did have a discussion about risk adjustment, and we opted to do an age-sex adjustment since we're comparing the entity to itself over time, and that was kind of the basis for why we didn't include a risk adjustment or clinical risk adjustment.
Just to follow up on that, there's always the potential that a new contract came on board that brings in a higher risk population as well, even though we're comparing same entity year over year. Just food for thought there.
Yeah, we've heard that. If it's a new employer contract with potentially like younger, it depends on kind of the population they're serving, and it could have that one-time impact.
thank you. Hector, Andrew, Iftikhar, and then David. Hector?
Thank you. Yeah, just want to support that we keep on our radar the whole issue of race, ethnicity, language, also sexual orientation and gender identity, and religion, so of course socioeconomic status. Those are all going to be factors when we look at who's moving the needle towards equity. The other piece, we learned about the limitations of age-sex demographics just by the Medi-Cal expansion to the patients with, now are called unsatisfactory immigration status, where we underestimated how much it would cost to take care of them because there was a lot of pent-up demand, and then there were other issues that led to higher costs, including pharmaceuticals. And so we need to be conscious of the fact that as we allow organizations that don't meet their targets to be able to explain how their population may be different from the broader data that we have on age-sex demographics. So something really important for us to keep in mind.
Thank you. Andrew?
Yeah, so I think it's probably a continuation from a couple of years when we were talking age gender factors, just transparency on what the factors are, right? So that the plans can calculate. I can't remember. I think these were based off of Connecticut or Rhode Island or something like that, age gender factors, but it's just, let's just be transparent on what they are. And also on the race ethnicity, the other data, I'd be pretty careful before you incorporate that because some of these populations are historically underutilizers. So when you actually bake it into a factor, then you're almost like baking in the underutilization, and you kind of don't want that. So just caution on that.
Thank you. Iftikhar?
Yes, on slide 47 and the characteristics of the population, I think is is fairly broad, but what's, one of our goals, which is in the statute, is to ensure we have access. So it's one thing. So I think we need to be clear on what population are we talking about. Is the population that is in your community and the population that you're serving? So there is a population of the underserved, obviously, that may not be served, right? So I think my suggestion is that a part of the success is that the underserved population does have access to your facility and to your access. So there should almost be a criteria to saying that you're not screening out the underserved and only treating either healthy people, wealthy people, people who don't have, people who are not the underserved.
Okay, thank you. David?
Yeah, thank you. In my opinion, when we set these targets, it's important these targets are viewed as being legitimate and reinforced with good analysis. And I know that when the target was originally set, the question was asked, should we risk adjust the target? And the answer was, we're not going to, because we don't think the risk adjusts very much year to year. It's not appropriate to adjust the spending target, the 3.5%, according to risk. And I think as a result of HR 1, I think you're going to see a substantial change in the risk of the Affordable Care Act exchange membership. I think the projections are they're going to reduce, unless something changes, they're going to reduce their membership by about 20 to 30%. And it's going to be predominantly the younger, healthier members that will leave, which will result in a higher average risk for the ACA population. And that's going to reflect itself in a higher total cost of care. So in my opinion, it will be better to make an adjustment to the target or have an allowable adjustment based on exposure to ACA membership in this process. Otherwise, you can have every single provider who has any exchange business making the same argument repetitively to you. And I think it's better just to proactively, we know the impact it's likely to be, and proactively provide an adjustment rather than have every provider explain why their risk went up and why it caused the healthcare cost to go up higher. So,
thank you.
One man's opinion. Yeah.
Thank you. Any additional discussion, comments? Carolyn? Mm-hmm.
I just want to emphasize that one man's opinion. I absolutely agree. It's just opening up this jelly bean bucket of everybody coming forward and having an excuse for not doing what we know is required. I mean, the cost, you're absolutely right, David. So let's just take the bull by the horns, shall we?
Thank you. All right, CJ, you want to move? Mm-hmm. Oh, yeah. Oh, I'm sorry, Carmen, go ahead.
Yeah, no, and I think as we enter into the world of HR 1, I want us to kind of step back a little bit because we did talk about the potential for risk adjustment along for many meetings, and I think we all, it wasn't a consensus, but there was a discussion of we wouldn't try to put the cart before the horse with overall adjustments of the spending targets until we know what those issues are. And I think this is I think in the context we were talking about certain types of pharmaceuticals increasing and these types of things. I mean, honestly, no one expected HR 1, but I think, we're just in the first year of trying to figure out how we enforce the spending targets. And if it does seem like after this first year, and this is why we have the staggered implementation, to see if we need to revisit. I think it's premature to say that we need to change the entire spending target just because of HR 1, because honestly, I don't think any of us, we're all very smart in this room, but I don't know if anybody can actually pinpoint what the percentage increase of potential growth from this year to next year will be because of HR1. And I just don't want us to like throw out all that work that we already did to, you know, to go back to risk adjustment now when we don't know what that's going to be. And taking the point that David was saying that there will be anticipated increase in costs because of all the cuts that are pending. Yeah.
I just want to. Oh,
sorry, I've got David and then Karen and then Joan. I'm sorry.
Sorry. I just want to be clear. I don't think this is throwing out the logic. I think the presentation from Michael Baylett was he showed over time minimal changes in the risk of the populations, and therefore the argument was don't adjust the target based on risk. And I just think we have a known issue, unless something happens with the subsidies, of course, that could change things. But if as expected, the membership in the Covered California goes down by 20 or 30%, there's good evidence there's going to be a substantial change in risk. And so I think the logic of the original target setting was don't adjust for risk because there's no evidence the risk is changing. If there's evidence the risk is changing, I think you have to re-ask the question. That's my point.
Thank you. Karen and then Joan.
Yeah, sorry about that. I think I agree with Carmen, but I wanted to just get clarification on this age adjustment piece, because what you're showing in the data and what you're saying on the slide is that it adjusts both ways, right? Up and down. So I guess I'm not clear on what that would look like in terms of enforcement. Like, I understand in one direction if they miss the target, but this is their excuse, maybe the enforcement would be lessened, but what happens in the other direction, if that makes sense?
It's a great question. I don't think we have an answer. I think this is the discussion that we are hoping to foster and engender here.
Got it.
Merely pointing out that it can work both ways. I also want to go back to a comment that Andrew made about where these risk adjusters come from. So as we described this in the baseline report, I had certainly not committed all of the baseline report to memory either. But each of these adjusters is based off of payer-specific data for the payer. So these are using their data and to create a baseline for each payer, and showing how their changes would impact them. And there's a write-up in the baseline report that gets into the details of that analysis, which I'm not going to dive into here today. But just to say that these are derived from payer data that was submitted to us and each adjuster is unique to each payer. But I do think, just to kind of engage in what do we do with the data, let's assume that an entity grew unadjusted at 3.6. We look at the age sex adjustment and it shows 3.4. That might be a reason to say, any entity that exceeds the target, as we've described, would receive technical assistance, but that might not move us towards public testimony or a performance improvement plan, and we would sit in a monitor and posture. Let's say that an entity grew at 3.6, and then we look at age sex adjustment and they grew at 4. That might raise them up on the what actions do we take next. So I think that it doesn't always work. Doesn't have to necessarily always work in the entity's favor, if you will.
Yeah, I guess that it seems like the problem would be if the cost growth was 3.5, which it's supposed to be, but the adjusted growth rate was 3, you wouldn't be able to say, oh, you should have hit 3.4. You wouldn't have any authority to do that. So it seems like if you did this on balance, you can do it a little bit in both directions, but only if they exceed the cost growth target. So I guess for that reason, I would have concerns about trying to adjust based on this, because you can't really take into account the full sort of spectrum of possibilities of what happened with an entity here. I don't know if that made any sense.
Thank you. Joan?
Question about what becomes public. So if an entity has missed their target, then their name and the amount of their miss becomes public, correct?
Yeah.
Is that before or after any of these enforcement considerations have been applied?
So our intention is to report unadjusted data as we did in the baseline report.
Great. That's fantastic to hear. Because we certainly wouldn't, that's great. If, as in the situation that Kieran was talking about a little bit, if someone made their target but would have missed it based on on the enforcement considerations, does that ever come into play?
I think, again, we're talking about these as considerations, that it's not necessarily deterministic. We're trying to have that discussion.
Yeah, because I think that especially in these early years, more transparency is helpful to help us see how those considerations, whatever they end up being, play out. And so getting more of that into the conversation can help us mature the process over the years. And then also the conversation about risk adjustment was bringing to mind a little bit of an overarching factor for me. So one of the real concerns about risk adjustment was it was gameable. And so as we're thinking about these enforcement considerations, it would be helpful to hear if there are any of them that you see as gameable, and sort of that as a flag for us. Because whether it is things like picking your patients and under-treating certain populations, or not taking Medi-Cal, not taking uninsured, or whatever other gaming. And so just how you're thinking about those would be helpful.
Great, thank you. Travis?
So in other states, in Massachusetts and Oregon, so if they're reasonable factors, are they still reported and are they still fined? If they're found to have gone over the target because of reasonable factors?
So Massachusetts, Oregon has not required an entity to go beyond, or hasn't required a performance improvement plan yet. They've laid out these factors. We'll continue to see what they do and take that in as we implement our program. Massachusetts has required one PIP for Mass Brigham. We'll be going over that in detail at a future board meeting or future AC meeting.
Thank you. Back to you, CJ.
All right, so next slide. Next, we'll discuss high-cost patient outliers. So the emergence of high-cost outliers has the potential to drive fluctuations in an entity's spending growth. After determining that an entity exceeded the spending target, OCA could work with the entity to determine the extent to which emergence of high-cost outliers caused the entity to exceed the target. In some cases, emergence of high-cost outliers may be outside the entity's control. Including this factor would enable OCA to consider random or unexpected events that drove volatility in an entity's spending in a particular year. I'll turn it back over for a discussion of consideration of high-cost outliers.
Andrew?
Yeah, so this is probably an area where it can get complicated, right? So the entities are all different sizes. Like an entity with 10,000 lives is going to have way more volatility than somebody that has 8 million lives. So it's one of these things where you're going to have to think through the thresholds and kind of just the group size where it applies. And also you get into, geo price differences, right? Things are more expensive in the north than the south. So, if you set a set threshold, more of the north would actually hit that. So it gets complicated.
Yeah, so if I'm hearing you, though, for relatively large plans that might have 8 million members, high-cost outliers probably don't change the overall picture tremendously.
It's a fact of life. So, like, every month I get a complaint from a random CFO that, hey, large claims did me wrong. And I'm like, well, you're a big plan. You have large claims every month. So that's just kind of where I am.
Smaller plans or smaller provider groups.
Yeah, smaller plans, you're you'll have one big case and it's going to hurt.
Suzanne. One moment, Suzanne, and then Marielle. Mm-hmm.
Thank you. I also am curious, maybe this is more of a comment. I haven't figured it out yet. But on the high cost patient outliers, I would be curious too, because the way that I was reading this was if a hospital has a high cost outlier, then they might say that was a reason why I wasn't compliant or wasn't able to meet the spending target.
the differences in costs maybe should be muted in those situations, because if it truly is a, life-saving 9-month PICU stay, then that's going to be high cost for anybody, any facility, any size. But then I think trying to normalize it and look at the DRG for what it would pay at Medicare, and then maybe set what a high cost outlier, high cost claimant is, based on something that's not stated by the person submitting the information. Mostly because then you actually we're talking about gamification. You can't, I think it's really hard to say that a PICU stay of that long isn't going to be high cost, but one entity might call that a $9 million claim, another might call it 4. And if the threshold is set at 4, is everyone just going to say 4? Right? If it's like 3.9, is it just going to magically become a $4 million claimant? So then I think if it's something that's not related to the actual setting of the price, and the billing center or the plan can set that price based on whatever the negotiated contracts are, and there's something different that states what the cost of that claim might be. And then if the price, this is so complicated, I'm sorry, but if the price is like $5 million, but the DRG has it at 2, then it's not a high cost outlier. And then that is part of the problem, if that makes sense, right? And that should have been closer to $2 million claimant, not a 5. Or maybe there's some. So, apologies, that was really complicated. I was trying to think through how that was the biggest thing that I could see, right? These high cost claimants become a really big challenge in the commercial market, offsetting other payers and whatnot. And so if you could pull down some of that noise a bit by trying to figure out what the definition is separate from the actual price of that claimant or claim, then it might be easier to figure out if that truly is something you can set aside. Because I completely understand that if you are a smaller rural hospital and you have that PICU patient, I shouldn't say how much they cost, but that PICU patient for 9 months, that should be set aside if you're pricing it somewhere close to what others would price that DRG at.
Thanks, Suzanne. You raise a lot of good points. I think this one is a complicated one in terms of what data we would collect from the entity. Many of these enforcement considerations, it would be ideal if they're quantifiable, then they're less squishy. We'll have to kind of take that back in terms of, how would an entity demonstrate high cost outliers. What we were looking for is, we know healthcare entities are going to have high cost claims every year. We are focused on kind of the unusual ones or the outlier ones that, had it not been for even more than the typical ones we receive, we would have been more in line with the target. I know I said a lot, but this one is a little complicated because sometimes there's cutoffs for they call it truncation, where you just kind of, any claim that's above 250,000, you just kind of remove it from the data set. We didn't do that at the beginning of OCA's process. We wanted to collect data on total healthcare spending. But then how do we kind of account for this? Because there are real situations that do occur like this.
Yeah, appreciate it. I'll end here, but the last comment being, I appreciate the dropping of the truncation, mostly because it is truly part of our healthcare system. And in some of the data I've seen, virtually identical patients, every patient is unique. So when I say virtually, there's probably still 100 things different between the two patients, but it was the same system, same transplant, and they were $1 million difference. And I was like, I can't even figure out how the differences come about. So I think it is still really valuable to look at these and just try to figure out how to work them into the data, as well as help give credit for the acknowledgement that these are patients that need really high quality care and need a lot of people around them. So they are going to be high cost. And we just have to understand that and be able to say, if that moves that facility
4% and they're only supposed to be at 3.5% this year, then we should give them that pass. But then the flip should be the case is like you can't just put that all the claims are 4 million as opposed to 2 million so that you can get that break. So I think that I appreciate that you're still looking at them and including them.
Thank you, Andrew. I think you wanted to add to that, and then Marielle, David, and Joan.
Yeah, so not to complicate this further, I probably am the same wavelength as Suzanne here. It's I guess in my mind, I hesitate to give like a complete pass, right? It's the analog is reinsurance, right? You still want the entity to have skin in the game to try to manage the costs. When you forgive the whole thing above a threshold, then it's kind of like, yep, it's like, oh, well, rack up the charges. I mean, at that point. So that's why you actually have to think through what this looks like. You could look at it multi-year to smooth it out. And the entity size actually does make a big difference here. Because big entities should be able to, large claims are a fact of life, even $1 million claims are a fact of life. So
do some of our payers or hospital systems have any kind of off-the-cuff thoughts on kind of a numerical threshold or multiple cutoffs depending on size? You don't have to answer, but if you want to chime in, you can.
Also add to that, it's not necessarily just a numeric, it's a change from one year to the next. So in 2022, you had 10 high-cost outliers, regardless of what the threshold is. We could figure out what that is for a particular entity. In 2023, there's 20, and you've got a patient population of small, 1,000, and that drives you from 3.5% to 4.5%, and we can look at that and then evaluate in an out year, did that number decrease, and then could again go back and rebase what your growth might have been with or without them. So it's not necessarily, I don't know that it has to necessarily be a dollar amount for every patient that's above X. We're going to recode. That'd be truncating. I don't think that's necessarily what we're talking about. It's really changes in the number of high-cost patient outliers from one year to the next.
Thank you, Marielle, David, Joan. Travis, did you have your hand up for the next? Okay. Oh, for that question? Marielle, would it be okay to have Travis answer? Great, thank you.
I do have some concerns with rural hospitals because there's such low volume and such a high Medi-Cal payer mix that a few patients can really drive us in the wrong direction pretty easily. My average ER visits are 12 a day. My inpatient census is 4. It doesn't take much.
Thank you, Marielle.
Yeah, I really appreciate this discussion. I'm wondering, what are your thoughts on some of the utilization and expenses we might anticipate in the coming years, given all of these federal changes? So for instance, with a lot of hospitals closing down, I imagine that there are going to be some, centers and health groups that are going to be taking a larger patient front. And then also, I think a lot of us anticipate that there may be folks coming in from out of state to use some of our services. So I'm just kind of wondering, how will these enforcement considerations hold up to what we're anticipating in the next coming years?
Yeah, I don't have an easy answer to that. We're definitely monitoring the impacts of HR1. As David mentioned, some of the ACA exchange population, if those are removed, then the average cost will go up. The employer market, in terms of the non-ACA employer population, that they're largely, HR1 doesn't really touch that population. Medicaid, huge changes. It's a little hard for us to predict.
Yeah, I think, just another concern that I'm hearing, there are so many seniors that we already know Social Security has its limitations, but there are so many who've also dipped into their own retirement funds, right? And so I can just imagine, expenses going up because of things like that. So I just wanted to plant that there's so many of these moving pieces that are going to force people out of a more affordable healthcare into a less affordable one, and it's going to impact all of our outliers and whatever predictions we might have. So I just wanted to make sure that we have that on our radar.
Thank you. David and then Joan.
I want to say a few more words about Suzanne's comments. One of the things I think you want to try to strive to achieve here is that you treat all providers the same and you don't treat some differently from others. And I think when you have high-cost patients, one of the things to think about is if you are a PPO plan, health plan with PPO members, if you have a high-cost member in a given year, that cost will show up in that year. If you have capitation, it could be hospital or physician, or it could be both, then if it isn't a carve-out, then sometimes the provider may have to absorb that cost within capitation. So in other words, in terms of total healthcare expenditure, the high-cost patient won't appear as a spike because it's borne by the provider under capitation. It may appear in the future in higher trends to catch up for those high-cost claimants. So just to be thoughtful about how you think about this. You could have an inadvertent outcome where you actually give providers with individual fee-for-service payments an advantage in navigating enforcement over those where it's absorbed within capitation and needs to increase the total capitation pool. My actuary here is nodding in agreement, so it has the seal of approval.
Yeah, I'm tracking how capitation could mask a lot of things, but the account will.
So I'm trying to explain. It would mask the impact in that year because the provider bears the cost, and it would give an advantage to a population that's fee for service, where the provider who's exceeded the target can explain, I had this high cost claimant. This is the cost associated with it. You should not, proceed with enforcement. You should give me credit for this. But you don't have that advantage if you're capitated. You've borne the loss. Yeah. But in the future year, you need to negotiate a higher increase to bear the cost of those claims
for serving that population.
Yeah.
Okay. So then next year you get a bump in your cap. Okay, but in the current year, you have to absorb it.
Especially remember, there are some claimants like hemophiliac patients, for example, who have extremely high cost drugs. And even if you have reinsurance, usually reinsurance will laser out a claimant after 1 year. So if we have a patient at Hill who has hemophilia, $1 million a year wouldn't be unusual. We would get some protection in the first year from reinsurance, but in the second year, we would need to bear that cost because you wouldn't be covered under reinsurance. So I'm seeking for equality here in enforcement considerations, and I just think you could have an inadvertent difference between fee-for-service structures versus APMs, which you're trying to encourage.
Thank you. I've got Joan, then Hector, and Andrew. Looks like you were going to add something, maybe. Okay, Joan and Hector.
I'm really glad David went first because the conversation about reinsurance is was one of the things that was definitely coming to mind for me, and also that difference in who's holding the risk. And so which entity in the entire system is holding the risk for that patient. And so all of that was bringing me a little bit back to this feels like one where there's data, whether it is on what are the reinsurance thresholds for different entities within the system and how do they treat patients, for example, the lasering out after a year. And also we have at least some information at the macro level about the trends in high risk patients. And so this feels like one where I would love to see substantially more data before really being able to make an informed recommendation here, which generally inclines me to not include it as an enforcement consideration from the outset and then see how it goes. Because if we are trying to figure out what's the difference between fee-for-service and managed care, and what's the right level for is it the same amount for a plan versus a rural hospital. All of that feels like a data project. And so if we have that data available now, great. But if we don't, then it feels like something to address as the program matures.
When you say we have the data, you're talking about the entities having the reinsurance?
I was actually thinking more, so that's some, yeah, the entities across the state know what their reinsurance looks like. And I am sure that there are academic studies out there that summarize it. That feels like the sort of thing that exists somewhere already, as opposed to a massive data collection project. Swear I've read something on it, but yeah, it's more what's out there available now to give us a little bit better grounding in what would these numbers look like, and how do we treat an entity with 8 million covered lives versus a small RBO versus a provider who's doing primarily fee for service, and just what do all of those different pieces of the pie look like?
Yeah, I think just from conversations with healthcare entities, I think it varies so much, the capitation arrangements and reinsurance and stop loss and drug protection plans. And so, yeah, I'm not sure there's a systematic source for that, but through this enforcement process, I think we could find out more.
Thank you. Hector, and then Barry.
Thank you. I really appreciate the discussion. I just wanted to throw in the reminder that HR1 affects all of us, everyone, because, the old saying is Medi-Cal goes, the rest of the healthcare system goes. Medi-Cal is so large and yet considered such an inferior payer that everybody starts looking for resources elsewhere. HR may very well trigger sequestration, which means Medicare will be cut significantly. And as that happens, then the cost shift to commercial plans will be a significant phenomena that we'll see. And as we've heard so many times from testimonials that, invariably the cost shift is shifted over to the worker and their families through premium payments, through their salary, to deductibles and copay. So HR will affect all of us, and that's what we need to proceed with. Thank you.
Thank you, Barry.
Well, Vishal, I was glad you expanded the discussion beyond reinsurance, because that really only applies to at-risk business, which most healthcare entities, maybe not the physician groups, but certainly the hospitals, have a minority of. Most of it is some form of per diem or case rate, in which case you have stop loss, which you point to. So as CJ points out, given, I think Dr. Weiss could comment upon this for an hour or so, given he works at a children's hospital, they might have a NICU, 15 NICU babies a year that trigger stop loss. And next year they have 18. That's a whopping increase. That would increase our percentage notably, and I think that needs to be factored in. So I think it's something that we need to continue to look at, because those are going to happen. And high cost drugs flow through. You have, as David pointed out, the hemophiliac. You usually have 3 or 4. This year you have 6, and that drug flows through because it's a carve out right to the health plan. The health plan reports it as a payment to the hospital, and bingo, their numbers go above the magical threshold. On a related topic, just thinking about what Travis mentioned with his situation, and the idea of making public the high-cost hospitals that trigger above that 3.5, we know it's going to happen, and I'm going to estimate there's probably going to be 150, 250 hospitals in the first couple of years that land on that list. It's public. It's picked up by the Sacramento Bee and the San Diego Union Tribune and the LA Times and the Register and the Sacramento or the San Francisco whatnot paper. And you're on the bad list, the high-cost hospital list. In his case, you guys do an investigation, provide technical support, find out, wow, he had 2 or 3 high-cost Medicaid patients that threw him over. That makes perfect sense. So it's public later that he was taken off that list, but when does the paper pick that kind of stuff up? So he's going in overdrive in his PR system trying to explain, no, we're really not a high-cost hospital community. We're working through this, but the game is over by that point.
Yeah, in our reporting, the intention isn't to say all of that spending growth was unwarranted. Like so we would want to frame it that way. Some spending growth is reasonable and expected. So we'll do as much as we can to frame it and to get the public or interested parties to understand what our program is about. So there is going to be an education piece to it. Regarding the high cost, the high cost hospital is kind of a different aspect. Like we wouldn't necessarily deem you high cost if you just exceeded the statewide target. But to your point about like we are mindful of that, the appropriate context and framing.
Thank you. Amanda?
Thank you. I know we're getting a little bit far away from some of the initial high-cost patient outliers conversation, but just a couple of the last points that have been made around cost shifting as a result of HR1, around being deemed a high-cost hospital and then maybe readjustments happening later. I think what we've seen with initial data, with the instance in Monterey and the special meeting that OCA had down there is just how arbitrary a lot of these prices are within our healthcare system, and I think with the potential for that cost shifting happening, and the potential gaming of that Suzanne pointed out and Joan pointed out around how do we game some of these things potentially to exceed. I just want to underscore, I think, how valuable it is to have OCA at this time, because of some of the incentives to cost shift to commercial payers, to try to make up margins when losses in income for Medicaid patients are because they're no longer seeing those patients, or changes to the risk mix are actually only impacting a small part of the the covered California market or things like that. So I think we don't want to understate how devastating HR1 will be to the healthcare system here in California, and also having the accountability that's inherent in OCA, I think, is incredibly important as we navigate what comes next and how hospital systems and are responding to those changes in ways that if there is not that accountability, may just be arbitrarily raising prices in order to make up for losses that are related to less patient care and are maybe appropriate.
Thank you. All right, CJ, next topic.
Alrighty, next topic. Previous slide. Getting ahead of ourselves here. I know we all want to get to the snack. All right. Historical spending growth. So OCA could evaluate an entity's longer-term historical growth. OCA could evaluate the average growth over several years or could evaluate the number of years an entity has or has not met the spending target. Evaluating historical growth could focus OCA's enforcement capacity on entities that have a consistent pattern of overspending. So again, just reframing and reminding everybody the purpose, what we're trying to focus on here is we're going to see entities that meet or don't miss the target. We may or may not have capacity to take action against every entity that misses the target. Some are going to miss the target by maybe 0.1%. Some are going to miss by percentage points. So just want to kind of foster this discussion around how should we be thinking about prioritizing entities for moving through, we refer to it colloquially as moving through the enforcement process from TA public testimony, HIPs, and ultimately penalties.
Andrew?
So I guess the question is, how does Massachusetts and Oregon do it? I think in Oregon they do like 3 out of 5 or something like that, or maybe it's a rolling. I can't remember.
Right, I think Oregon's process prior to getting to financial penalties is that an entity would miss the target for 3 out of 5 years prior to penalties. I think that's even getting further downstream from where we're trying to focus here, which is sort of year over year. How are we going to be evaluating?
I guess, I mean, probably not for today, but you have hundreds of entities that are reporting, right? So it's not, I mean.
We have 51 plans that'll be reporting, but then we also, so we have plans, provider organizations,
Right.
Hospitals, right? Yeah, so there's many entities. Ultimately.
Yes.
Mike?
So semi-broken record, I think this is where you could be applying some of those quality metrics. So if there's an investment in preventative and primary care, the corollary of that would be better rates of screenings, better immunization rates, better well visits, those types of things. And factoring that in might make a difference as you're thinking about the enforcement.
Thank you. Others? Travis and then Andrew.
It's almost a hard question to ask without seeing what the results are, to see if, wow, whole hundreds blew by this or 15 blew by this. So, I mean, it's hard to answer ahead of time until you actually see what things look like. Because, I mean, there's a clear pattern, like certain groups are. I mean, maybe that's basically you move the make different targets for different areas.
Thank you. Andrew and then Sumana.
Yeah, so I'm a big fan of a rolling 3. I mean, maybe it's the ACA in me, but rolling 3.
I mean, another way to contextualize this, without, obviously we don't have years worth of spending data for California to report on, but you know, if I have 2 entities and one has grown like clockwork at 2% over the target for 4 years, might think about that different from one entity in 1 year that grew 5% above the target. But in the prior 3 years had met the target. And I've got limited bandwidth.
Sorry, more thoughts. And similar to what we, the staff did on the hospital side, right? So you kind of look at a distribution of, where people are falling, and you will have outliers. So if you have outliers year in, year out, then that deserves different attention.
Thank you. Thank you, Savannah.
Yes, to follow up on the comments from Hector and Dr. Weiss on the HR1 side and the APMs and all the work that we've all been geared to sort of see come to a better fruition over the next few years. It's hard to square that with keeping costs down when so many of our patients are going to be uninsured, showing up at hospitals sicker, and we don't know what to expect around the degree of uncertainty that that's going to pose. Even in a small practice, we're going to lose patients off of insurance. They're going to lose all their carefully calibrated accesses, however hard we try to continue to take care of them. And that increases costs. So,
Thank you. John?
Just wanting to, on the rolling 3 or 3 out of 5, point out that the OCA process has already been years in the making, and the idea of waiting until we have 3 years of data or even 5 years of data to get to starting to move toward enforcement seems like forever.
Thank you. Amanda?
I just want to second that.
Thank you. Moving on, CJ?
The next one is impact on consumer access and affordability. The degree to which spending has adversely impacted consumer access to affordable care. This can include statewide and regional market share and impact. And just to elaborate on this one, we did not want to just say entities with large market share. So market share isn't really the best attribute because that could vary. You know, there's certain entities that are more regional, have more of a regional presence, but just wanted to speak about kind of the size and impact of an entity on spending trends.
Discussion, Joan?
I like the concept. I think that I personally would take out the word spending and just say the degree to which the entity has adversely impacted access to affordable care. I'm thinking about entities that are doing basically capture and kill, where buying a competitor and then closing them down, and then that leading to overall increase in prices in the market, or closing unprofitable services in a way that hurts access. There are any number of actions that an entity can take that is impacting consumer access and affordability other than just their spending.
Thank you. Carolyn?
I just want to echo Joan's thoughts here because that is really critical. We're already experiencing that. That's what I mentioned this morning with the hospital closures in Northern California. The Glenn County situation is not the only hospital closure. We've had 5 federally qualified healthcare clinics close. Now our second major hospital. This is an impact to cost. There's no way around that. So if we just look at this and one word can make a difference here, if we hold this to just spending, you're missing a lot of other factors out there that are raising costs. So I 100% agree with Joan. Let's just say the entity and look at more than the spending that they're experiencing.
Thank you. Amanda?
Question, could you talk a little bit about how you would measure this? Like, what are some of the metrics you would use? Data you have access to?
Yeah, for plans, it could be their enrollment. For hospitals, it would be different. It could potentially be discharges. For physician orgs, it could be membership. So it could vary.
Thank you. Iftikhar?
I think there is an opportunity to make this more measurable. And I think the comment made earlier, I think made a lot of sense that the way this is worded, if you remove those keywords of cost, just adversely impacted access, that is more measurable than putting the qualifier of cost in there. So I would second the comments made earlier, and that would actually make it more measurable as well, because with that, though, it becomes very philosophical and direct.
Thank you. All right, continuing on.
So the next one is investments in primary and preventative care. So the office could evaluate the degree to which spending, or the degree to which increased spending or investments in primary and preventative care cause an entity to exceed the target.
Travis?
I think that's extremely reasonable because in the future, the cost of care in that area should go down because you actually increased access. So it should just be a blip of an increase temporarily.
Thank you. Carolyn? Yeah, turn it on and give it just a moment. It might take a moment.
Is that better?
Yeah, there you go.
I think we're going to echo this word spending throughout this entire screen because this is very concerning. Everything being measured just on spending. Everything I see here when I look at this, you shut down a hospital, for example, that's less spending, but the impact to the cost of healthcare once you shut that down is astronomical in the region or to the individual patient who now already has to travel for other services because they don't exist there, now has to travel to the closest emergency room to get care because you've closed down the local hospital or federally health qualified clinic because your spending margins aren't there to justify keeping that door open. So there must be a way to expand this to where we're not just looking at the spending costs for the entity, but can we dig a little deeper here? Is there something we can build in to say we're going beyond just what this is costing you?
Thank you. Sarah, and then Amanda.
I guess I was thinking along similar lines in that pairing things like increased investment in primary and preventative care with other measures to see if the increased investment really is improving patient care or creating more access, maybe data that the DMHC or DHCS has on access to timely access to appointments.
Thank you, Amanda.
Comment and then a question. I think one of the reasons why OCA has, I think very rightly focused on investment in primary care is because over time, investing in upstream, primary care interventions should reduce overall cost to the system if if we're able to manage chronic conditions and things like that. So, I mean, I would be interested to see, over time, how these investments balance out, and am appreciative for the time that OCA has put into to the primary care benchmark. On this enforcement consideration around investments in primary and preventative care question, is the investments, are you looking at an individual hospital facility or the health system overall?
So our focus or healthcare entities are defined in the statute as payers, providers, and physician orgs, and then we don't have a health system definition currently in state law, but we do recognize many of healthcare entities are part of systems. So kind of regardless of how you're organized, we'd want to be able to somehow measure and quantify this and evaluate kind of how the spending is being used to support expanded capacity at the healthcare entity level, as defined by OCA, as defined under state law.
Iftikhar?
Yeah, I didn't understand. So if if we're limited to just the hospital, investments in primary care you will not find those in the hospital.
Yeah, are you thinking of, so our primary care benchmark, which is a related effort, that requirement is on payers to increase primary care payments or investment, but entities themselves could also be investing in primary care separate from what payers are doing. So hospitals that are part of systems, they could be, expanding clinics or other areas if I'm tracking your question, so we could get requests from hospital, or a hospital could come forward and say, if this were to become a factor, we would just need a way to measure and quantify it.
So my point was that we should consider the data, but not let the fact that it's not in the hospital deter from looking at the data. So usually investments in clinics are not in the OSHPOD report, but that entity may be making investments in the clinic. And as long as we word it such that we're willing to look at the investments and not restrict it to just the reported data on the hospital level, there's nowhere to report that in the OSHPOD reports under the hospital structure.
Thank you. We've got Mike and then Hector and Travis.
Just curious how you guys have defined primary care. Is that internal medicine, family medicine, pediatrics, OBGYN? Do you remember what sorry, because it does matter, and especially on the OBGYN side as it relates to hospitals. Oh, did I? Oh, okay. That I missed. Okay.
Mike, we can send you our definition of primary care. Yeah, and happy to talk more about it offline if that's helpful.
Okay, thank you. Hector?
Thank you. Yeah, and Mike, it's fairly broad. The definition of primary care is what the specialties you mentioned, including OBGYN, but there may be some specialists that are also the primary care for a terminally, cardiomyopathy patient, for example, something like that. So my comment, going back to Iftikhar's question, is really looking at even a hospital. What one of the aspirational goals of OCA is to drive forward alternative payment models as everyone participating. And so for a hospital that may be doing episodes of care bundle payments, they're going to require to have a strong primary care base before the patient gets that bundle payment service, and then after, to make sure that there's patient reported outcomes that are long term. And of course, as Vishal mentioned, if it's a healthcare system, they're going to be looking not only at potentially those episodes of care, but they're also going to be responsible for population health, which then, it really means strong primary care in the community and even specialty care in the community to make that population health dream happen. So I think there's a lot of aspiration here and some movement in that right direction. Thanks.
Thank you, Travis.
I was just going to throw out an example. I mean, we bought a mobile health clinic to increase access in our community. We're going to open another RHC. So, I mean, I don't think that we should be penalized for investing in our community and increasing care. So that was the example I was going to throw in.
Thank you. All right, moving on.
So the next one is entity baseline costs. So not all entities will begin operating under the target from comparable baseline costs. In addition to measuring and comparing the entity's percentage growth, OCA could prioritize enforcement actions with entities that have inexplicably high costs and absolute high growth.
Comments or questions?
We could go on to the other one, but we could happy to return to this as you're stewing on it. So the next consideration is high-cost drugs. New therapies and new uses of existing drugs may lead to unusually high spending growth due to increases in demand, cost, or availability. We would need to evaluate the extent of control and any excessive markup behavior by entities when evaluating high-cost drugs as an enforcement consideration. So I'd probably ask, you're free to weigh in now, but I will be having an extended presentation on high-cost drugs. So plenty of opportunity to comment then as well. And we'll be returning to we'll be covering that after we're done with this set of slides.
Great. Joan and then David.
In the entity baseline costs, I would encourage finding a different word other than inexplicably, because it's often explainable. It may be something inappropriate. It may be greed, or another inappropriate reason, but it's often going to be explicable.
So just removing the word.
Or just figuring out what it is we're actually trying to say there. If it's costs and growth that are not captured in the normal course of business, or just really getting at what we're doing there, because there often is an explanation. It's just not going to get captured in a broad cross section.
Okay, thank you, David, and then Andrew.
Yeah, so today I'm trying to focus on principles, and one of my principles is that if you have an industry-wide issue like ACA, in my previous comments, then instead of having providers individually request redress through enforcement, you try to adjust the approach. And the one I want to focus on with respect to drugs is the impact of tariffs. So I know it's a bit of a moving target from the federal government right now, but it appears that tariffs are going to increase drug costs across the industry for all providers in different ways. And I think, again, instead of having providers have to beg forgiveness for the tariff impacted costs that they can't eliminate, it would be better to figure out some way of adjusting for the impact of tariffs. They will become clearer next year of what they actually are, but I think it's clear they will have an impact. Something like 90% of the drugs that we consume in the US today are made outside the US in places like China, India, Ireland, and others. So I'd advise figuring out some way of doing a tariff adjustment next year to, instead of having every provider try to explain why tariffs impacted their healthcare costs.
Thank you, Andrew, and then Carmen.
Yeah, on the baseline costs, I think I'm back to the work that the team did last year on hospitals, right? You look at the outliers, folks that are outside one standard deviation on either direction, just a starting point, because you have hundreds of entities you have to deal with. On high cost drugs, definitionally, are we talking about, do you have a set definition? Is it like costing 600 or something?
No,
like that?
we don't have a threshold. It's it could include physician administered drugs, specialty drugs.
Carmen?
I was just trying to kind of go back to what, because a lot of this, it seems like we're trying to figure out how to prioritize enforcement, right? With all these different enforcement considerations. And I agree with David that we should focus, like if the issue is trying to help OCA identify which entities have not met the target, to look at enforcement actions first, going through technical assistance to PIPs and moving forward to penalties, then I think it makes sense to kind of not look at the folks like David was saying that are impacted by ACA changes, HR1 changes, and looking at and I think that's probably what we're all kind of struggling with, because there's a lot of considerations here, and it's essentially we're trying to prioritize it. And this is mostly like a point of clarification about what we're talking about here, which is, so we're trying to prioritize which one of these enforcement considerations, and the description of the enforcement considerations, we're kind of moving entities forward for enforcement. Is that right? Okay. Which I think makes sense with, looking for entities that that go over their comparable baseline costs, or the impact on consumer access. And I think when it comes to high cost drugs, there's probably something there. Well, see this one's a little bit weird, because it could have the same similar impact as what David was saying, which is like there could be one drug that impacts multiple entities. So I guess this one might be less on the side because it's not under the control of the entity. I think that's really the difference between some of these factors is what is in control of the specific entity and what is not. And I think that's why the primary and preventive care piece we were kind of struggling with because it's because there's a little bit of an analysis of like whether or not that investment is actually going towards effective primary and preventive care. And I think those are I'm just kind of laying out the issues that we're all struggling with here.
Thank you. David, and then Kieran, and then Tam.
Just one clarification on my comment earlier. Of course, tariffs would apply across all drugs, potentially, not just the high-cost ones. So my proposal was to have an adjustment across drug costs overall for the impact of tariffs. And again, as Carmen just said, the notion is if it's outside the control of the provider to impact, then it's not fair or reasonable to ask them to explain or rationalize why they couldn't handle the impact of tariffs. Good point. And medical supplies are almost all imported. Yes.
Thank you. Kieran, and then Tam.
Thank you for laying all of this out. I am just concerned. This is a lot of different excuses that are under consideration. I'm concerned about the capacity of OCA to sort of manage the many, many, many different requests and things that you may get from entities subject to the cost growth target. If all of these become potential enforcement considerations, that just seems like an unworkable process. And so I would encourage you to really just, in terms of prioritization, it's really what is the mission of OCA, which is consumer access and affordability. So the entities that have exceeded the cost growth targets in a manner that most impacts consumer access and affordability should go to the top of the list for enforcement. But I don't believe there should be sort of waivers based on this, that, and the other thing, with the exception of somewhere on there is like catastrophic events. That one makes sense, but I just think we really need to stay focused on the mission of the office. And if we end up in a situation where there's 10 different sort of exceptions and entities arguing for them and you're having to adjudicate all of those, it feels like that could really impact the effectiveness of the office.
Thank you. Tam?
I was just going to suggest that we finish the list of considerations and then revisit high-cost drugs in the next conversation that Michelle flagged, because there are 18 slides just on high-cost drugs alone.
Thank you, Tam.
So I think maybe we could take the next two together, since so the first one is changes in state or federal law. So entities may be affected by changes in state or federal law. These can include state benefit changes or mandates. Mandated wage increases or federal tariffs may increase an entity's spending significantly. OCA could consider the extent to which these changes impacted an entity's spending growth. Sudden and unexpected changes in federal trade and fiscal policy could also impact the cost of care. And then if the office sees a systematic effect that applies uniformly across the healthcare system or to sectors of the system, that information would be presented and considered for future spending target setting. And then the acts of God, these are events that are unforeseeable, often caused by forces of nature and beyond human control. OCA could assess the extent to which the event was foreseeable, or if the entity failed to take reasonable precautions to mitigate damage. And then lastly, OCA could take into account acts of God and catastrophic events as contributing factors to an entity's excess spending.
Comments or questions? Yeah, David, and then Andrew, and Amanda.
Yes, I think these are important. And, as an example, I'll just tell you that the IVF mandate that was implemented this year in state law has an effect of increasing total healthcare costs by about 1 to 1.5%. So some of these are have a material impact when you're managing to a 3.5% target. And again, my advice to OCA and the staff is to instead of having providers, as someone was just saying, have like 10 different things they're listing as the reasons why they've not been able to reach a target, adjust the target for the known issues that are outside the control of the providers. Examples are ACA risk changes, IVF mandates, tariffs are 3 examples. And therefore have the providers focus on explaining those issues that were in their control that have contributed to missing the target. And that would be a far better way to focus the efforts, in my opinion.
Thank you. Andrew and then Amanda.
I mean, I was going to say what he said, but it sounded better coming from David. The one thing I would add, though, it's like the fertility mandate. It's not just the mandate; it's all the downstream stuff from it, right? So you'll have the maternity around it. You may have a NICU stay around it. So it's one of those things where, when you look at mandates, you're going to see a fairly expanded view of kind of all the downstream effects.
Thank you, Amanda, and then Stephen, and then Iftikhar.
Not to be contrarian, but I actually think in many cases changes to state and federal law can be anticipated and can be accounted for. We have good infrastructure here in California through CHBRP. The IVF mandate went through an extensive actuarial analysis with Covered California and state lawmakers. We can quantify those impacts. There was extensive modeling that went into what those costs will be, and so I think that is true of other benefit mandates. That is true of many state and federal regulatory changes, and so I think actually in many cases these are knowable impacts and things that many parts of the system can plan for. They may not choose to plan for them, but I do not think that should be justification for an exemption because an entity chose not to plan for something that was foreseeable.
Thank you, Stephen.
Yeah, I think David and Amanda raise an issue that I want to elaborate on because I think it's going to be a cross-cutting issue throughout everything that OCA does, and it has to do with what's controllable, right? And I was reminded of this a bit, and it's also short-term, long-term to think about it, with a conversation I had about 2 weeks ago with a chief medical officer of a hospital, not in California, and she shared the following. Her hospital would probably be a high-cost outlier, perhaps, here in California, because she said they have a fair percentage of their patients, she estimated 10%, who sit there in the hospital bed for 2 or 3 days beyond the point at which they can be discharged. Okay? A lot of nods of the head. Because there aren't post-acute facilities in her community to discharge these patients to. So you can easily see how for a given year, the hospital should not be penalized for those higher costs if that's the case, right? So if you look at this from a community, population-oriented improvement of people's health in that community perspective, and the hospital's a major employer, maybe it's part of a system with relatively deep reserves, relatively speaking, could you then make an argument that, okay, you're absolved this year, maybe next year, but the third year, no one else is stepping up. We expect you to invest in the post-acute facility so that that patient can get the appropriate care. It's going to be lower cost than sitting in the hospital bed, long run, to control the affordability and also perhaps the quality rather than sitting in the hospital bed and ulcers and falls and so forth and so on. So I'm just saying, I'm not, just using that as an example. We had an interesting discussion with her about that. What's controllable at a given point in time, and what might be expected from our healthcare organizations to innovate, to think about the health of the community. If there aren't things in that community, well, you need to step up and long run make that kind of investment. Could be post-acute facility. It also could be new kinds of partnerships with community-based organizations, investment in more food, housing, social determinants of health, So they're not ending up in your emergency department, costing you more, et cetera, but you got to spend the money up front to do that prevention work. So I just want to raise this thing about what's controllable versus uncontrollable is going to be an ongoing kind of consideration.
Thank you. Iftikhar, Sarah, and then Tam.
So in the second bullet where we list the state and federal changes, my suggestion is to expand to include access. So state rules can change access, federal rules, especially the HR 1 will change access. And I hear the earlier comment by Amanda that the connection between those changes in those laws and the changes in cost need to be demonstrated. It cannot be arbitrary. And so, but I think by not listing it, it seems like we're eliminating that from the list of considerations, which I don't think is reasonable, because eventually it would lead to providers either turning away patients who need care or going out of business.
Thank you. Sarah?
I think I advocate for caution in using changes to state and federal law. I'm thinking like of a specific example where we've had, I believe it's been since 2016, a law in our state to ensure adequate provider networks. And that just has not been followed. And so now there's, I think, at least 2 bills in our state legislature to create some sort of consequences to entities not complying with that. And so that would be, if one of those passes, that would be a new law, but it really is a reflection of the old law either not being regulated, adequately, or just not being followed. So there's a lot of laws that get passed to try to make sure laws like mental health parity are enforced, even though things like mental health parity law have been around for a very long time.
Thank you. Tam?
Yeah, I was going to just, we've had like extensive conversation on the impacts of HR1, and I think those should definitely be accounted for as appropriate. And I'll also just note that there are going to be more coming changes from both the federal government and also state government as folks, consider what the impacts of HR1 is, and the state's going to have to make a number of decisions as well. And then on the federal side, and for public hospitals, including the county hospitals and the UCs, we are on the lookout for additional proposed rules that would impact safety net financing and state-directed payments for public hospital systems. And so that's something that's very concerning as well. That would also impact the reimbursements and payments that we receive for Medi-Cal as well, and will likely increase uncompensated costs there.
Thank you. Joan?
A question about what this slide represents. Are you seeing this as sort of an impressionistic painting of how this would go, or are you seeing this as a bulleted list, as a list of what the factors would actually be as we talk about what else we'd want to include and what not? I just wanted to get a better understanding of how you see this list.
Yeah, sorry, I'm not.
Because they're like under the second bullet there are a couple of really specific state benefit changes or mandates.
Yeah, these are the specific ones that have come up quite a bit, the mandated wage increase and the tariffs. And these are new state or federal law. So that was kind of the focus of the second bullet, is primarily on new impacts.
Okay, so you see that as a fairly exhaustive list rather than just how we're kind of thinking about changes.
I think we're trying to draw these out by way of example, and I think obviously the way we think about this in year 1 is going to be different than the way we think about it in year 5, and the way that we think about wage increases aren't going to hit every single mandated wage increases by state law are not going to hit every year. So I think these are all by way of example for us to generate thinking around how the office would approach.
Okay. That's helpful because I was hearing some different ways of treating this throughout the discussion. I do also worry about a chilling effect on progress. And something like the IVF mandate, if that's included in a list like this, does that make it harder to pass in the legislature? Basically, does that then change how the fiscal note on a bill comes into play? Or is it something that has to be taken into account in an analysis of a bill of what would be the interaction with OCA? And that leads me toward real caution toward putting any kind of specifics out there, because you could really create some gnarly interactions.
Thank you. David?
Yeah, so first of all, I just want to say that I think when mandates are passed by the state legislature, there's always an argument about how much they're going to cost, and usually the authors argue it's very small cost impact, and others have different opinions. But I think the fact that there is a mandate that increases healthcare costs is unavoidable. And I think it's not a lack of planning. It's just that you're adding additional services. And as Andrew said, sometimes the services themselves, such as IVF expansion, cost something, and then the downstream costs of more multiple gestation, more NICU babies, et cetera, are often not fully accounted for. My point is, the point I'm trying to make is that the state of California, through OCA, is trying to reduce the rate of increase in healthcare costs and setting targets to try to do so. If another part of the state passes laws that increases what's included in total healthcare expenditure, then in my opinion, the state should adjust the target to reflect that. It's not reasonable to ask providers to strive to meet that target when another part of the state is increasing benefits, increasing the mandate to cover services. It might be a very good idea, but we can't avoid the fact that when you expand services available, they are going to cost something, and some of these mandates have a material impact and cost. So that's the argument I'm trying to make.
Thank you. All right, how about a break? Okay, the time is now 2:18. Let's return at 2:30. Thank you. All right, we will continue on this agenda item.
So now I want to turn to some work OCA has done on enforcement considerations. So in this next set of slides, I'll be summarizing some initial conversations we've had with entities, including some from the organizations that have representatives on the advisory committee on the topic of high-cost drugs as an enforcement consideration. So we met with 8 stakeholders, which represented plans, physician organizations, hospitals, consumer advocates between May and July. There's some kind of old language from the one meeting remaining in July. That meeting did occur. Discussions focused on high-cost drugs as a mitigating factor for exceeding the spending target. OCA was trying to understand the extent of control, trends in high-cost drugs, relationships between various entities, feedback from entities on how to operationalize a consideration for high-cost drugs. The conversations primarily focus on physician-administered drugs versus retail pharmacy. So on the next slide, this is just a little background on drugs and some of the key players in the field. So we see some of the differences between retail drugs and physician-administered drugs. This distinction is important because there are several, there are significant price differences for the same drug depending on whether it's administered in a hospital, outpatient department, inpatient department, physician's office, or purchased at a retail pharmacy. So on the left, retail drugs typically purchased by a patient at a retail pharmacy covered under the pharmacy benefit of a health plan generally include oral medications, some injectables, and other medications that can be self-administered. On the right, physician-administered drugs are usually purchased by physician offices or a hospital and administered to a patient covered by the medical benefit of a plan. They typically include infusions, injections, and medications administered in a clinical or hospital setting. This slide shows the various stakeholders and their role in obtaining or administering drugs, paying for drugs, and advocating for changes. First, starting with health plans, they contract with entities referred to as pharmacy benefit managers or PBMs to manage drug benefits, including categorizing drugs into tiers. They also pay for drug costs and administration fees. Physician organizations administer physician-administered drugs. They monitor patient responses and manage potential drug interactions. Then we have hospitals, which obtain medications from licensed pharmaceutical wholesalers or group purchasing organizations. They manage inpatient and outpatient drug administration. Consumer advocates advocate for policy changes that make drugs more affordable and accessible. They also support accountability for drug companies and healthcare entities. So go to the next slide. So this is a visual illustration of various entities and their role in pharmaceutical contracts, payments, shipment, and administration. You'll see that it's a very complex set of relationships with various levels of contracts, rebates going in multiple directions, and shipments going in multiple directions. And then going on to the last kind of background information slide. So PBMs emerged in the 1960s to manage prescription drug benefits for insurance companies. They handle claims processing and reimbursement. Some of the current trends we're observing is formulary management, in which PBMs determine which drugs are covered by plans and at what cost to the patient. They also negotiate rebates with pharmaceutical companies, but the impact of these rebates on drug prices and patient costs is a subject of ongoing debate. There's also vertical integration, where some PBMs have merged with or have been acquired by insurance companies, pharmacies, or pharmaceutical companies, raising concerns about potential conflicts of interest and anti-competitive practices. On the right, we have GPOs. They emerged in the early 20th century as a way for hospitals and other healthcare providers to pool their purchasing power to negotiate lower prices from suppliers. They leverage their buying power to allow smaller entities to access the same discounts as larger entities. Current trends, GPOs have expanded their roles just beyond procurement. They also do data analytics, logistics, digital transformation strategies to improve supply chain efficiency. They've faced criticism for potentially limiting competition and choice and for the complexity of their operations and financial structures. So going to some of the key observations. So this is kind of summarizing all the observations, and then we'll go into observations by type of healthcare entity or type of stakeholder. So now I'll highlight some key observations from meetings with healthcare entities. Healthcare entities all note limited ability to control drug costs, anti-inflammatory, oncology, ophthalmic, diabetes, and obesity drugs were identified as high-cost drugs, driving spending. New therapies and new uses of existing high-cost drugs were also identified as key drivers of drug costs. However, they could also reduce cost growth through regular introduction of biosimilars, including increased biosimilar adoption strategies and increased use of generics. There's also changes in pharmacy benefit manager there could also be changes in PBMs and contracts, which could be common, but this can result in changes to prices and formularies. And then the lack of transparency in pharmaceutical pricing mean entities along the supply chain can increase costs and markups. And then continuing with key observations, entities provided the following suggestions listed here. Some suggested referencing Oregon's model when developing OCA's enforcement considerations for high-cost drugs, referencing data from the NASHB hospital cost tool, such as the cost-to-charge ratio, using charge masters and counter data, hospital pharmacy reports, information about high-cost drug carve-outs from contracts and 340B discount information to verify drug costs and trends, collecting data on which drugs are highest cost and determining their impact, evaluating the division of financial responsibility between a payer and provider in capitated arrangements, examining any cost savings from PBMs. So in the next set of slides, I'm going to go share specific information about types of stakeholders from specific stakeholders. So from our health plan conversations, they report that their influence over drug costs is limited and dependent upon contracts with PBMs and GPOs. They reported the following cost drivers listed here, such as high-cost drugs like autoimmune, anti-inflammatory, rheumatoid arthritis, and oncology, diabetes, and skin condition treatments, increased utilization, new therapies. On the other hand, cost mitigation strategies include contracting with multiple PBMs, developing creative group purchasing arrangements, managing utilization via prior auth, presenting cost information at the point of care to prescribers and patients before a script is written. And then continuing on to the next slide, plans also noted they often carry financial risk for many injectable drugs due to requirements under state law. They referred to this as the Richmond Bill requirements. So under the Richmond Bill, health plans cannot delegate risk for the injectables listed here unless there's a negotiation with the capitated provider to assume that risk. So these negotiations result in varying configurations for financial risk between plans and providers. There could be a full Richmond carve-out. Groups taking capitation could take on chemotherapy risk only or high-cost risk only. And then going on to the next slide. So plans noted the following barriers to managing costs. PBMs could be changed for a better price, but this could lead to changes in formularies, which impact consumers. Specialty drugs may have limited distribution channels through high-cost facilities. They brought up the issue of drug manufacturer copay cards, which encourage patients to choose branded drugs. And then allowing patient choice for drugs may lead to selection of high-cost brands, hospital markups on drugs beyond the wholesale price. Plans noted that Oregon's broad approach to high-cost drugs as a reasonable factor is a good model and suggested additional consideration of entry of new high-cost drugs, new uses, or updated guidance about the length of course or where they should be administered, and increases in demand, cost, or availability. So going on to physician organizations. Physician organizations report that their influence over drug costs is limited and depends on negotiations, with health plans for higher reimbursement payments. They reported that drug cost drivers include the various items listed here. Some include new high-cost drugs, new uses of high-cost drugs, tariffs on supplies and medications, and increased demand, such as for new vaccines or from aging baby boomers. They also reported the following cost mitigation strategies: negotiating with health plans to remove high-cost drugs from their side of the Division of Financial Responsibility, or DOFR, utilizing drug protection plans offered by health plans, internal cost-saving initiatives such as encouraging biosimilar adoption, redirecting to different sites of care, for example, from higher cost facilities to preferred sites, and reference pricing. And then on the next slide, physician organizations with regard to retail benefit drugs. Generally, physician organizations do not bear financial risk for retail drugs unless they are part of a health system that has risk for some or all retail drugs. With regard to medical benefit drugs, financial risk for physician organizations can vary in their financial responsibility for office-based medications, vaccines, and outpatient medications delivered in outpatient facilities. Some have full risk for home infusion medications and inpatient medications. Many high-cost drugs are rolled into hospital claims that are billed under the medical benefit. These aren't as easy to identify compared to retail pharmacy claims. And then lastly, a physician organization reported that when there's a material change that has a significant impact, this is an opportunity to renegotiate their capitation rate. And they give an example of new vaccines as an example. And then one last slide about physician organizations. They reported that a small number of high-cost drugs are responsible for outsized amounts of their cost growth and drug costs, similar to trends observed elsewhere in the market. One example was given for the drug Keytruda, which has a cost of $200,000 per patient per year. They've experienced a significant increase in usage, as it had one second-line indication in 2024 and has since increased to 49 indications with multiple first-line indications and used in combo therapy with other high-cost medications. Usage is among a small portion of members, but represents an outsized share of total medical drug spend. Physician organizations also suggested excluding drugs from the cost target with new codes for a new first-line indication on claims, excluding a limited number of high-cost drugs with no cost-effective alternative, and potentially drilling down to a subset of codes that could be compared year over year. And then going on to hospitals. So hospitals report that their control over the cost of drugs is limited to what their GPO or PBM is able to negotiate for them, what they're reimbursed for by Medi-Cal and Medicare and health plan formulary decisions. Hospitals shared that drug cost drivers include oncology agents, specialty biologics, cell and gene therapies, as well as ophthalmic injections, expanded utilization, such as GLP-1s being used for cardiovascular treatment. Some mitigation strategies proposed by hospitals include switching GPOs to get better pricing, but note that this isn't easy. Negotiating to exclude high-cost drugs in contracts. They also noted some high-cost drugs mitigate overall spending, such as curative medications for sickle cell disease, for example. And then going on to the next slide, For critical access hospitals that bill by charges, they typically charge over 2x the average wholesale price of the drug to cover the cost of labor and supplies. One hospital noted that because they're paid per diem or capitation on the inpatient side, they don't get paid more for providing more services or drugs. One hospital noted that as an employer that also provides coverage for their employees, they looked at their self-insured plan and noted savings opportunities. Switching a dozen patients alone from Humira to biosimilars could save millions. However, to achieve those broader savings, it would require prescriber and patient education and being able to obtain this data from their PBM. And then lastly, some hospitals discourage or disallow white or brown bagging because they can provide all drug needs through their own pharmacies. This approach enables them to reduce delays for patients and minimize waste. White bagging, just to be clear about that terminology, those are drugs that are shipped directly from specialty pharmacy to medical providers for administration. Brown bagging are drugs that are dispensed to patients who then bring the drug to their medical provider for administration. And then just one last slide on hospitals. One hospital noted that they are able to negotiate their contracts with GPOs when there's been a material change, such as new vaccines or new high-cost medications. They noted that treatments for some indications like cancer can change from year to year, impacting costs and potentially impacting performance against the targets. They suggested OCA make cost adjustments for inflation, expensive and rare therapies, and whether hospitals opened any new service lines that are having an impact on drug spending. One hospital suggested OCA focus on the misuse of high-cost drugs rather than volume when considering high-cost drugs as an enforcement consideration. Hospitals also suggested examining the impact of high-cost drugs by looking at drug revenue codes from claims and comparing high-cost drugs year over year, evaluating evidence of changes in costs like a charge master or hospital pharmacy reports, using encounter data to tease out the medical benefit pharmacy costs that are bundled in capitation payments. And then one last set of slides from consumer advocates and the feedback we received from them. So consumer advocates suggested that OCA look to the NASHP hospital cost tool to reference what Medicare fee-for-service reimburses for drugs and compare how many times a hospital is charging over Medicare. Advocates noted that markup of drug costs are driving high spending. While some markup is understandable, they stated that markups of 4 to 5 times of what Medicare is paying is unjustified. Markup behavior may be associated with the market power of the entity. Advocates also remarked on the problem of hospitals marking up already excessively high-priced drugs, such as those priced in the millions, and this results in costs that are passed on to consumers and payers. And then lastly, consumer advocates noted that health plans, especially those with a large national footprint, should have purchasing power to drive down drug costs. So, I know that was a lot to throw it at everyone. To kind of focus the discussion, we do have some set of questions here for you on how to consider high-cost drugs as an enforcement consideration. So one way to think about this could be the size and impact of drugs on an entity exceeding the target. For example, some costly drugs are highly utilized, GLP-1s could be used over a broader base of the population, while other drugs have relatively low utilization, but have high launch prices, such as cell and gene therapies used by a dozen or so patients. There's also significant market changes. Some changes increase costs, such as new therapies, while others come down in price through patents that expire. And then there's the issue of determining who to hold accountable. Given the varying configurations of financial risk and delegated models. There's the issue of excessive markup behavior, and then data, how to think about data information that healthcare entities could submit to OCA to help distinguish between controllable overspending and external cost pressures.
All right, let's open it up for discussion. I've got Sumana and then Mario and then Ken.
While this is something that so many of you have talked about in the last couple of years on the lack of control we have on where these drug prices are set and all that sort of thing, recognizing the challenges faced by hospitals and large groups, there are so many ways that when you talk about cost mitigation strategies, there's so much low-hanging fruit here that's actually not being addressed, whether it is effective alternative detailing to clinicians, which I think is a huge aspect. And examples might be, we've talked about GLP-1s and the fact that a lot of headlines now are, what proportion of people who are started on them are continuing them, for example. How much are we addressing side effects, et cetera. So I think we can control these costs much, much better by making sure indications are clear. Support when the decision is made to start them is improved. One aspect. Second, good data to stop the most wasteful care. And I don't think anybody here has referenced that scam that hopefully you're mostly aware of around skin substitutes and Medicare, and that these companies came out of the blue and started charging Medicare, from $150 per square inch from a few reputable companies to tens of thousands, and I believe maybe even hundreds of thousands of dollars for square inches. So that's a whole scam you can read about. But if we don't have the data, we can't catch these things early. And we only caught this because groups that are invested, as you all want to say, that skin in the game, caught this early. So that was the Medicare ASB, MSSP in my case, Aledade, that gave me a heads up on this in my community, months before it became common knowledge. So I think we have to work together to recognize that those kinds of activities can really help control costs. And then we should be aware that groundbreaking new research that we've all been a little bit worried about, like gene editing technologies, and we know that these are like $1 million pop. But today there's an article in the New York Times about a company with a rare disease. 2 people were treated and effectively, but the company's gone out of business because we're not willing to pay. So that particular disease treatment for an ultra-rare disease is now gone. I know I'm throwing out so many issues here, but they really impact how we think about high drug costs specifically.
Thank you. Mario, Ken, and then Amanda.
Yeah, thank you. This definitely a lot of criteria to weigh out. I have a couple of questions. My first question being, I don't see anything here in particular with regards to, and this is a situation that I know I've encountered, other people have encountered, where you're picking up a prescription script from the pharmacy and it actually costs less to buy it if you don't use your insurance. And that happens quite frequently. And the thing is, if you don't know to ask, right? It's not something that you're even going to think about, right? And most people don't think about it because you kind of assume that if you have coverage that, that is doing its job in subsidizing your out-of-pocket costs. So I'm wondering if that's something that's going to be considered in this type of enforcement.
So that is a real issue, and there is state law that does require the pharmacist to, if the cash price is lowered, to offer that to the consumer. But from our kind of, like, we don't have jurisdiction over drug manufacturers, so we would just focus on spending by plans, hospitals, and physician orgs. So that would be out of scope for us.
Okay. And then I appreciate that. I have another question about just marketing. There is a lot of talk about GLP-1s, but there's also a tremendous amount of advertisement on GLP-1s. So I don't know how that will be taken into account. Surely, part of the expenditures have to do with marketing, but also they get so much more back because so many people want them. My other concern with a drug like GLP-1s and the cost, and every time we think of any time there's a new indication, right, the clock on its ability on generics kind of restarts. So that's another cost. So if we're really considering that, what is the FDA? Well, where does the FDA come in? And then I think the other question with a drug, again, just like GLP-1s, for example, is that you've got so many manufacturers trying to, capitalize over the desire for weight loss, right? So I don't know necessarily who all of the manufacturers are, but I'm sure that these are factors that play into driving costs. So I guess the overarching question is how are we, or do we have any kind of interest in considering like marketing techniques and things like that pharmaceutical companies employ to get folks to ask for those drugs?
Yeah, that's kind of more the domain of the federal government, and states don't have as many tools to deal with that. But plans themselves, they could do utilization management on GLP-1s and to make sure it's being administered appropriately. But the marketing aspects would be out of scope for us.
Thank you. Ken, Amanda, and then Suzanne.
Thanks. I'm not sure where to start. I should do it with an apology because I'm sure I'm going to offend some of the industries that are represented at the table today. My career was as an administrator and a consultant to large group plans, and we paid our own claims, so we saw all the costs come in. The thing with prescription drugs is I don't really know if there's much that can be done because nobody has real control over what the costs are here versus in another country. Sovaldi, when it came out, $84,000 here, $600 in India. But purchasers and consumers have really less than zero say. In my former group, fortunately, we controlled our own destiny, and through our PBM, we actually operated about 50 to 60% below their average cost for their whole book of business. And that was just by very closely monitoring the formulary. We excluded drugs that were replaced by lower cost, equally effective drugs. So, but OCA can't be looked at as the purchaser, and the health plans are purchasers in some veins, and others not. I know that we had issues with hospital-billed oncology charges that we refused to pay because we were advised by an independent consultant that looked at each and every one of our prescription drug claims every month to confirm, number one, that they were paid proper in accordance with the contract pricing. And that was an issue at times, and also just monitoring prescription of the higher cost drugs and letting us know where we could get our participants to make changes and lower it. But, you know, we were looking after ourselves. Our health plans weren't doing that, and a lot of the PBMs won't do that. The other thing is we had issues with oncology drugs, and we found out that a charge code was up by 1,900% by 1 year to the next. And it just so happened that next year my plan had an abundance of oncology claims. We refused to pay the portion of the charges that were considered above usual and customary, but the health system put so much pressure on the health plan, contending that we were putting them in breach of their contract, that the purchasers and consumers had not one word of involvement with. And in the long run, we got it straightened out, but we didn't pay that difference. And the next year, those charge codes were corrected. So this facet of the industry, which is the runaway train now, I don't know how you're going to be able to effectively carve out, because there's just so many moving parts that are detrimental to purchasers and the consumers. But I hope you can do it.
Thank you. Amanda, Suzanne, David, Andrew, Tam.
Thank you. You know, I think it's fair to acknowledge that there is a part of pharmaceutical costs that are out of the control of the covered entities that we're talking about here in OCA. And we also, you know, it's also not appropriate to say that there is no aspect of pharmaceutical costs that is within the control of a regulated entity, within the control of hospitals or plans or some of these other agencies. You know, I think to Marielle's point about, you know, cash prices, and, you know, which is covered by, you know, other laws and regulations, you know, I do think that it underscores where there are more opportunities for plans and hospitals to use their market power to reduce prices. It should not be cheaper for one individual consumer to pay cash to, you know, to purchase pharmaceuticals. And I think that is an area where there could be some control, and we should expect these entities to be looking to control pharmaceutical prices and not just saying, well, you know, we're going to pass that along to the consumer and we don't need to worry about that. We know we're going to get ours. I think that is where OCA can step in and you know, have an expectation around containing some of those pharmaceutical costs. You know, and additionally, you know, a significant area for OCA to look at is markup. This is can be actually a huge profit center for some healthcare entities in California, is around, you know, 6 times, 7 times, 8 times, 10 times markup on drugs for the prices that they pay, whether that, you know, particularly in inpatient administered drugs. But that is completely within the control of the entity. How much they are marking up those pharmaceutical drugs is completely within the control of the entity, and something that should you know, should be examined as OCA is looking at how to treat pharmaceutical costs in terms of these exemptions and potential exemptions. And then just a question, you mentioned, I think, 340B in part of the presentation, and how is OCA planning to measure cost for 340B drugs? Will it be the cost that the you know, a hospital or clinic actually pays to the pharmaceutical company? Is it the cost that the insurer plan is paying? How do you plan to measure those costs?
So I do want to clarify that the enforcement considerations aren't exemptions. Just a minor kind of tweaking to the language. They're considerations on how we prioritize who we enforce and kind of how they move along through the process. But to your question about 340B, for hospitals, as part of the HCI financials, they include those payments in the 340B. We don't have like line item breakouts of kind of the amounts, but it's kind of, there's a kind of revenue, and then there's some deductions they make, which include 340B discounts and such. So not a lot of visibility into the specifics of those amounts, but they are supposed to be part of the way they submit the HCI hospital financials.
Thank you, Suzanne.
Very much appreciate all this work, 'cause I know a lot of us were asking for a number of meetings, like we'd love to see it. So thank you for this. I also disclaimer what I'm about to say, that I am not a healthcare professional. I think everyone here knows that. But if I get over my skis, I apologize. I kind of, looking at spend, kind of like Ken talked about in a lot of data on the back end, I'm kind of bucket these and for the discussion into preventive, treatment, and life extending. I generally, and this is all like principle based, not practice, that if it's a preventive medication, it should not matter if it's expensive or not, or highly utilized or not, because the idea is that it's offsetting other expenses potentially within that same facility. And we are requesting, like in the GLP-1 example, we are requesting advancements in primary care, or even if you are a hospital, not totally, maybe a facility that's prescribing GLP-1s, maybe a hospital wouldn't, but a facility might, that there should be some tie into it, that if you're taking a maintenance medication, and we actually saw this in our data recently, there was a gold carding process, which if you're not familiar, kind of bypasses any utilization management. And I've also heard this from some friends who work at hospitals, that whenever that happens, there is a lot of utilization for outside of the FDA guidelines. And so I think those checks and balances, while painful sometimes, are really valuable. So if there's high utilization and, you know, reasonable cost or low cost, I would expect that that offsets other costs in the system. The treatment one, I won't really touch, because that's a lot of single source brand drugs or multi-source, hopefully, selection into, you know, step therapy, helping manage this. But the last one is life extending, and I think a couple of people have mentioned that it's understandable that there would be some situations where oncology just keeps getting brought up. It's not the only category, but where there's a new oncology medication, it's extending someone's life. And I think that's maybe the one area to me where it's really interesting to figure out, like maybe just new to market, not at the facility level, right? A facility has typically 30 patients, an oncology center has typically 30 patients of this particular, on this particular treatment, and then the year after that they have 40. I think that shouldn't matter as much, because they're managing those patients and they have other peaks and valleys. But maybe if there is really legitimately a brand new drug above a certain size per fill or per year expected, maybe per year is a bad one for that category, but I think that would be like a very, we'd be able to then classify this as just in the J code, Q code, because most of these are not in the retail pharmacy space, or you could look on both sides, but that's mostly asking hospitals to report out, back to a lot of people are talking about the potential markups, but instead of asking them to reveal things like that, right? It's like asking for a provider contract. You're probably going to have a hard time getting that, because it would show what would be called proprietary information, that at least you'd then be looking at, you'd be able to look at the Medicare price set if a drug is over X amount per fill or per regimen. And if it varies from a Medicare price a certain amount, then that's when it cannot be taken out. I think I kind of said that backwards. If it's, let me try that again. If it's above a certain threshold of price on the Medicare side, like an ASP plus model, then you look to see whether or not it can be removed from the hospitals, or sorry, the entity's claims data as like an outlier. And if you see that they have 5 patients on that treatment, and of those 5 people, back to the percentage, if they are all more than 200% of Medicare or the ASP model,
then that does not get excluded, or maybe that overage doesn't get excluded. So I guess in summary, that was more comments, because I guess in summary it was like, my thoughts are that preventive medications, even if they are more highly utilized, and I am calling GLP-1s preventive, because even though they are treatment, the idea is to manage type 2 diabetes or weight-related conditions and chronic conditions. And then separately, life extending, I think there is a place to get a little bit more specific on how you can potentially pull out very specific drugs in a given year.
May I just respond to that? May I just respond to that?
Yeah, briefly, and then we're going to wrap this topic up in just a moment.
Yeah, I think that's a really interesting comment and question. I think that the challenge is, how do you define life-saving drug or life-extending? For instance, like all the various formulations of insulin, right? That's all of that. So I just want to, caution on that difficulty. That was just my comment right there. Thanks.
Okay, so I've got David, Andrew, Tam, Ken, and Stephen, and Hector, and I am kind of keeping an eye on the time here, and then we'll wrap this item up. Okay, David?
Yeah, I believe that there's a substantial amount of profit hidden in PBM complexity. Lots of artificially increased prices that are offset by rebates that return to the PBM. Does OCA have any ability to get transparent information from the PBMs? Because I feel that if we're only looking at the hospital and the physician organizations and the health plans, we're going to miss a substantial portion of these cost drivers if we can't see into the PBM economics.
So David, are you talking about the total cost, like net price?
Yeah, and in the same way that you're getting information, underlying information from physician organizations and hospitals and health plans through the claims information, I'm asking, will you be able to get insightful information from PBMs about the prices for drugs and the markups?
We will eventually. Under the Budget Act, the recent Budget Act, there's PBM reform, so they're going to have to be licensed by DMHC. And then HCI is going to require them to submit data to the HPD, which will include the cost information, so rebates and any other kind of rebate-like payments.
One other quick comment I'll make is I noted the mentioning of white bagging and brown bagging, and just a warning from the physician side of the house. White bagging is a nightmare to manage because you have one single plan who has a different way of shipping the drugs and matching up the shipping of the drugs to the patient, and now you're not using your pharmacy anymore is a real big problem. And then brown bagging is even worse, because think of it, if you're a physician infusing a drug and the patient arrives in a bag, they got it directly, you don't know, you have no way of verifying if that's the correct drug, has it been stored properly, but if there's a bad outcome, the physician office is on the hook for that. So I'm just a cautionary note about those cost containment strategies. They have unintended consequences.
Okay, so quickly we'll get to Andrew, Ken, Stephen, and then Hector. Thank you, Ken.
Yeah, just a couple other thoughts about this. Is the word rebates has been lightly mentioned, but rebates consist of a large percentage of the price. Going back to when Sovaldi and Harvoni came out, $28,000 a month, there was an $8,000 rebate built into that price. That was just unnecessary other than just straight profit. And as it turned out, our PBM kept it. They didn't even give it back to us as the client. So these are ways getting rid of the rebates would be a big help, step in the right direction. As far as cash prices, does anyone here know how GoodRx works and does what they do? Because I had $1,000 a month, no, $1,000 for 3-month prescription that was not in the formulary of my health plan that cost me about $20 every 3 months. So I don't know how that happens, but it does. And so having everybody use GoodRx, I didn't hear that. Please, Jim. Tell you what. How's it work? I don't know. But, you know, the other thing is, you know, I know this is not going to be popular with the health systems and the providers, but if, you know, Medicare, CMS is allowed to negotiate and establish their rates. I don't see why there shouldn't be some degree of uniformity within this country, in particular tying it to what the same drugs cost in other countries, as I mentioned before. So, I mean, there's proactive measures that could be taken.
Thank you. Stephen and then Hector.
Yeah, by design, no one knows. That's the way they like it. This whole area is a whole mess. I'll be very brief. It's an example of the unwarranted complexity we have in our healthcare system. Everybody has their finger in the pie, and some twice. So my suggestion, the way forward here, is to continue to talk, spend a little bit of time with the plans again, the physician organizations, et cetera, and the others, and maybe with some PBMs. And thank God for greater transparency. I'm glad to hear that over the PBMs that may be coming down the pike that will enable you to get some of the data you need. But just look at what are the 2, 3, or 4 controllable factors, right? So formulary management would be one, maybe. What about your GPO? Is there a better one out there that you could look to, for example? What about reference pricing? You know, can you refer reference pricing? Is that something that could be done as well? 3 or 4, and then just forget the rest. This is just focus on a couple of those things and move forward.
Thank you. Hector, and then I know, Mike, you've got a comment. Hector, go ahead.
Yeah, thank you. Yeah, I think, you know, the main thing would be for OCA to use the full extent of its regulatory powers to get transparency along the whole pathway of, you know, from the pharmaceutical company to the patient, kind of like farm to table on the food side, right? But because there is so much gaming of the system, you know, we've heard the discussion today about the PBMs and their behavior, even the 340B program. There's, you know, most people use it wisely, but there's also some abusers who find it very profitable, and they've started to extend into commercial markets using the discounted drugs that they bought. So that's human nature. And what I learned in my days at Kaiser was that you control a lot of that by having evidence-based guidelines of how you develop your formulary. So that's to Steve's comment about formulary management. And then you educate the physicians to make sure that they're using evidence to guide their patients into what the best treatment for is, not necessarily what they saw in an advertisement on TV, and explain the reason that medication may not be useful for them. And it takes time. You have to develop that practice style to allow that time for the physician or clinician treating the patient to have a substantive discussion with the patient. So at the same time that we look for transparency and the gaming that goes on, it's really looking at how we can continue this movement towards alternative payment models, which are the great equalizer. Everybody then starts rowing in the same direction, and you put a lot of emphasis on the clinicians who at the end of the day are going to make the decision about those treatments. And you stop the gaming of the settings. You know, I've seen providers, you know, oncologists and hospitals game the system depending on where they're going to get paid more. Is it an infusion in the hospital or infusion in the office or somewhere else? The transparency will eliminate a lot of that gaming. Thank you.
Thank you, Hector. Mike, and then we'll wrap this topic.
Yeah, just real quick, we have kind of a natural experiment that we probably could learn from, and that's 50% of the patients in California are under Medi-Cal RX, right? And there's probably some really good data on whether we've been able to flatten the curve in the last 3 years or plus that we've been doing that. And I think that would provide us, A, some data, and B, probably some best practices to think about as we implement this and think about what we could put in place.
Thank you. All right, that concludes discussion on this item. We will now move to public comment. If you'd like to make a comment and you're in the room, please step to the podium. If you're online, please raise your hand. I know we've got a couple hands raised that have been raised online, so I will start with our virtual attendees. Please keep your comments to 2 minutes or less. Sean, please go ahead. Sean, we can't hear you on this end. You are unmuted on our end, but you might need to unmute on yours.
Can you hear me now?
We can. Thank you.
Thank you. Sean Kim from California Pharmacists Association. I want to acknowledge OCA's valuable work in examining high-cost drugs. However, I'm deeply concerned that pharmacies were not included in the recent stakeholder discussions. Pharmacies are centered to how patients access, pay for, and adhere medications, yet their perspectives are missing. The presentation slide employed the Drug Channel Institute DCI's 2021 mapping. The DCI's 2025 mapping makes clear that PBMs and GPOs are vertically integrated and deeply interconnected across insurers, manufacturers, and pharmacies. These relationships give PBMs extraordinary power to steer patients through network design, formularies, and utilization management. Patients often do not have the freedom to choose the provider, medication, nor not to forget the pharmacies, even when clinically appropriate and cost-effective. 347 Rite Aid store closures that just happened a month ago already highlights the fragility of the access when care is financially unsustainable. This is precisely why Senator Winner authored the SB 41, the Pharmacy Benefit Manager Reform Bill, which CPHA is proud to sponsor. Governor Newsom has already enacted another budget act establishing PBM licensing and accountability. HCI, in collaboration with DMHC, will play a critical role in collecting and analyzing PBM data and identify the cost drivers across the system. Pharmacy must be included in the stakeholder in those conversations. Pharmacies see firsthand how PBM practice, like non-transparent rebate structures, excessive DIR fees, and patient steering, and drive up total health care costs while reducing access. CPHA strongly urges OCA to formally include pharmacy organization and collaborate with CPH to help design the data collection, acknowledge the pharmacist's role. Thank you so much.
Thank you. To the podium.
Hi, Brad Schmidt again. I was going to, just to the room for like a comment, there's a great conference next month in New York City. It's with the SCI New York. Leader in the PBM space is Mark Cuban. I'm not affiliated with him, I just like what he's doing. It's all about cost plus and pricing transparency, and SEIU New York is a good example for how to think about this. So if anyone, I think it's an online, if you want to check it out, it's October 9th. I'll be there, but if you want to check it out, it's a good way to go. The other one to consider, I mentioned Sage Transparency earlier. If anyone in the room is interested on hospital pricing in the United States, you can actually figure out medication bill charges above what Medicare pays on Sage. It ranges from 125% in our market to 387%. It's widely publicly available. If anyone wants their website, I'll send it. I'm not affiliated with Sage either. I'm just sharing kind of public information. Anyway, and then finally, the one thing I see, I'm in oncology, the one thing I see a lot in oncology is the statistics that are kind of shared or sold to physicians or care teams. Frequently, a drug company might come in and say, hey, this drug is 15% better than another one. So for example, I was at a small cell lung cancer talk. The generic was $500. The T-cell drug was $50,000. Statistically, it was 15% better, taking the patient's life from 10.5 months survival to 12 at a cost of $50,000 for the drug. But then when you factor in the markup at the health system, it could be, if it's 400% markup, it could go from $50,000 to $200,000 per injection. And then you factor in the rebate, there's a lot to it. So the statistical quality is really important to consider. I know it was mentioned earlier, but I call it quality. Quality could be a great standard for California to consider. Thank you so much.
Thank you. Looking virtually, Carrie, I see your hand raised. Go ahead.
Good afternoon. My name is Carrie Hurley. I'm from the University of California, Irvine School of Pharmacy and Pharmaceutical Sciences. I'm a practicing pharmacist and clinical associate professor and a member of the California Pharmacists Association. Echoing the comments of my colleague Sean Kim, who spoke previously, as this committee considers approaches to spending, target enforcement, and other issues, I want to emphasize the critical role of pharmacists in ensuring healthcare access, reducing unnecessary costs, and keeping care patient-centered. Pharmacists are frontline providers who do far more than dispense medications. We collaborate in managing medically complex patients and their regimens, help avoid costly hospitalizations, and improve medication adherence, all of which directly impact whether spending targets are met without compromising quality or equity. We're clinical medication experts, but many of us also have expertise in the administrative aspects of the use of medications. However, in today's discussions, pharmacist perspectives are notably absent. In particular, enforcement decisions related to high-cost drugs, PBM contracts, and the distinction between retail versus physician-administered medications cannot be fully informed without pharmacist input. Your own materials show drug spending is a key driver of cost growth, and without pharmacist voices, the enforcement framework risks overlooking the drug distribution channels, formularies, and PBM practices that shape costs and access. Pharmacists can speak to many of the very complex questions that have come up today, including how GoodRx works. I would advocate that the California Pharmacists Association sponsoring SB 41, the PBM reform bill, be included in these stakeholder processes. Pharmacists bring unmatched expertise in how PBM practices and drug pricing structures impact patient access, affordability, and their subsequent outcomes. If pharmacists are not at the table, enforcement risks focusing too narrowly on targets and penalties rather than forward-thinking strategies that can actually reduce costs for patients and the system. In closing, I urge OCA and HCI to ensure that pharmacists and CPHA are actively engaged as you move forward with spending target enforcement and other issues. Leveraging our expertise will strengthen your ability to enforce affordability in ways that improve patient care. Thank you.
Thank you. To the podium.
Good afternoon, Jenny with the California Hospital Association. First, we want to align our comments with David Joyner, Barry Abucco, and others here today. Overall, we're looking forward to the continued discussions on how OCA will assess enforcement on entities that exceed the spending targets, especially since the current established targets do not account for any key drivers of healthcare spending growth. We support the inclusion of many of the factors introduced by OCA today, and also including high drug costs to OCA's question, and recommend expanding the list to include additional factors such as microeconomic trends like rising inflation, as well as payer mix, changes in insurance coverage and uncompensated care, provider financial distress, and labor costs. Factors that support and expand patient care, like investments and expansion of services, technologies, and programs, should also be accounted for. Additionally, we urge OCA to implement a meaningful process that gives entities the opportunity to respond and provide additional data and information as to why they have exceeded the spending target, resulting in an off-ramp enforcement when this information speaks to the reasonableness of the spending growth. This process becomes even more important when considering that not all factors can be predicted in advance or were built into the spending targets themselves. Thank you.
Thank you. Looking virtually, Jeffrey, I see your hands raised. Go ahead.
Hi, can you hear me?
Yes, we can. Go ahead.
Perfect. Thank you. My name is Jeffrey Nahira. I am a pharmacist. I'm director of pharmacy at a company called NutriShare, but I'm also a board member of Sac Valley PHA, Sac Valley Pharmacists Association as well. Just like Sean and Katie said, pharmacists, need to be kind of consulted regarding the processes. A lot of the things that you're questioning on the call right now have to deal with how things are reimbursed, as well as the challenges that patients face that drive up the cost of healthcare. As they mentioned, SB 41 helps with both the transparency with the PBMs, as well as it will help this committee understand what's driving up that cost of healthcare. In general, as you may know, just like Sean said, a lot of pharmacies have been closing. And as these pharmacies close, institutions and offices such as yours are losing valuable resources regarding the ability for us to check with individual patients their best, most affordable treatment plans and work with their physicians as well as work with committees like yours. Perhaps this committee, and as you mentioned, so this committee has talked about physicians are unaware about how their prescribing habits are impacting that patient care. Perhaps figuring out a way to have the physician groups partner with pharmacies or pharmacists individually to help manage in a group setting their individual patient care plans to help minimize cost would be a great way to focus the affordability of most patients, especially those with special needs. Thank you.
Thank you. Seeing no one at the podium and no other hands raised, that concludes public comment on this item and takes us to our final agenda item number 5, update on behavioral health spending definition and measurement methodology, including summary of public comments. I will turn it over to Assistant Deputy Director Margaretta Brandt.
Good afternoon, everyone. Margaretta Brandt, Assistant Deputy Director for Health System Performance at OCA. I know it's been a long day, so feel free to stand up, take a stretch if you like during our presentation. So in this portion of the agenda, Debbie and I, Debbie Lindis, our Healthcare Delivery System Group Manager at OCA, and I will provide an update on the behavioral health workstream. First, we'll share findings from a data analysis of behavioral health spending from the Healthcare Payments Database, or HPD. This is a follow-up on what we presented to you all in June. And then we will review our proposed approach for measuring behavioral health spend and look at the comments that OCA received during our public comment period on the methodology, which took place in August. And we look forward to your questions and feedback towards the end of our presentation. So if we can move to the next slide. So as we usually do, just a reminder of OCA statute. For behavioral health investment, OCA has 2 related but distinct activities for behavioral health spending. First, OCA is required to measure the percentage of total healthcare spending that goes towards behavioral health. And second, we are required to set a benchmark for behavioral health spending that sustains infrastructure and capacity and shifts resources towards supporting and facilitating innovation and care improvement in behavioral health. And moving to the next slide. So regarding our mandate to set an investment benchmark, the Healthcare Affordability Board decided at its June meeting to defer the adoption of a benchmark until at least next summer. And I'll also note here that the statute does not require that OCA set a benchmark by a certain date here. And the primary reason for this postponement is that the board did not feel comfortable adopting a benchmark based on the limited understanding of the current level, past trends, and future potential of behavioral health spending that currently available data provide. And the extra time will allow OCA to use its existing data sources such as HPD to conduct additional analyses of spending to inform our benchmark recommendations, and the board and URL's deliberations and input into the benchmark. And this means that the behavioral health spending data that we will start to collect from payers for the first time in September 2026 will only be used for measurement and reporting, not for comparison to the benchmark. So the timeline for data collection is laid out on this slide. So this is the timeline for the first round of behavioral health spending data collection from payers. Payers will submit aggregate behavioral health spending data for the first time next September. The submission will include spending data for 2024 and 2025, and this data will be included in the first report on behavioral health spending that will be released in summer of 2027. Another note here is that statute specifies that entities required to submit spending data to OCA are payers and fully integrated delivery systems. So this includes commercial health plans, Medicare Advantage plans, and Medi-Cal managed care plans. On the next slide. So the data submissions for behavioral health spending will include claims and non-claims payments for behavioral health care using the definition that we'll review in a few minutes. And the data will be aggregated by year and by market category, so commercial, Medicare, and Medi-Cal categories. And non-claims payments will use the expanded framework, which we will look at again shortly, to categorize payments for analysis and reporting. And the detailed methodology for how to report behavioral health spending and how to organize data in the data submission will be included in OCA's data submission guide that will finalize this spring, so spring of 2026. So moving to our behavioral health spending analysis. So this, we hope, will provide some context for the discussion of the measurement methodology that follows, and then also is a follow-up from our discussion in June to share mental health and substance use disorder spending broken out for our behavioral health total spending. So if you could go to the next slide. So the purpose of this analysis was to look at trends in spending for behavioral health, mental health, and substance use disorder over time and by spending subcategory using commercial claims data from the HPD. And at our June advisory committee meeting, we presented the overall results from this HPD analysis. And today we're sharing behavioral health spending broken out into its two components, mental health and substance use disorder spending, since that was an interest of the advisory committee. And I'll note here that the data are categorized as either mental health or substance use disorder spending based on the primary diagnosis on a claim. And this analysis used the methodology for identifying behavioral health spending that was developed by the Milbank Memorial Fund and Friedman Healthcare. And OCA's proposed definition and measurement methodology that we will review in a few minutes aligns closely with this Milbank methodology with a few modifications. So moving to some key takeaways from these analyses. So first, commercial spending for behavioral health care increased by about $2 billion from 2018 to 2023, or about 65%. Spending for substance use disorder services grew at a slightly faster rate than spending for mental health services. And still, mental health services account for about 7 of every 8 commercial dollars spent on behavioral health care, with the remainder going to substance use disorder services. Spending for mental health services therefore drives the distribution of spending across subcategories for all behavioral health services. So when you combine behavioral health or mental health and substance use disorder services, that the mental health services really drives the distribution of spending. And for mental health and for behavioral health overall, spending in the outpatient professional, pharmacy, and inpatient facility categories drives spending. And most commercial spending for substance use disorder services is in facilities, including inpatient, residential, outpatient facilities, and emergency departments. If you could go to the next slide. So the next two slides show the relative contributions of mental health and substance use disorder spending to total behavioral health spending based on commercial claims. Again, the categorization of mental health or substance use disorder is based on the primary diagnosis on a claim. So overall, as I noted, total behavioral health spending increased by about $2 billion or 65% from 2018 to 2023. And in 2023, commercial mental health claims spending was $4.5 billion and substance use disorder spending was $623 million. Mental health spending increased about 63% during this period, while substance use disorder spending increased by 80%. And on the next slide, so because substance use disorder spending grew at a slightly faster pace than mental health spending, the share of all commercial behavioral health spending attributable to substance use disorder services grew by 1 percentage point, reaching 12.2% in 2023. And the largest jump in this percentage was from 2019 to 2020. You could go to the next slide. So our final slide in this section shows the share of commercial claims in 2023 going towards mental health or substance use disorder services, respectively, by subcategory. The subcategories are broken out in the chart. So this view shows very clearly how mental health claims, the blue bars, are concentrated in the outpatient professional, non-primary care, pharmacy, and inpatient facility subcategories. In contrast, substance use disorder claims, the orange bars, are barely represented in the outpatient professional, non-primary care, and pharmacy subcategories. And residential facility and inpatient facility claims are the largest service subcategories for substance use disorder spending. I'll also note there were more dollars spent in the residential facility subcategory for substance use disorder claims than for mental health claims. And inpatient facility, outpatient facility, and other expenditures that are those are the expenditures that are not placed by the methodology into a specific subcategory, are also substantial subcategories for mental health spending. And before we kind of wrap up on our data, I also wanted to note that this analysis was recently published on the HCI website and is available there. The web link is hci.ca.gov/bhspend. Sorry, that didn't make it onto the slides, but we can also share that link afterwards. But wanted to make sure that you all are aware that this analysis is also on the website as a resource. So in our next slide, and we'll turn to our next topic, I'll turn it over to Debbie in just a second. We'll walk through our proposed methodology for defining and measuring behavioral health spending, and we'll also review our public comments that we received on the methodology. Sure.
Of the 5.1 billion in total spend you had there, do you know what the denominator is in terms of how many members that accounts for?
I do not have that off the top of my head.
Okay.
No.
All right, thank you.
Yeah, we would be happy to follow up and.
Great, thanks.
Yeah.
Thanks, Margaret, and good afternoon. We can go on to the next slide. I'm Debbie Lindis, the Healthcare Delivery System Group Manager at OCA. So OCA's behavioral health measurement methodology includes 3 modules of spending that you can see here on the slide: claims, non-claims, and behavioral health and primary care, which includes both claims and non-claims spending. This is the same structure as the methodology for measuring primary care spending that we developed last year. And I'll go through each of these modules in turn. On the next slide, we'll start with claims-based spending. And these are the high-level principles on which OCA's proposed method for measuring this spending is based. So first, all claims with a primary behavioral health diagnosis will be included in the measurement of behavioral health spending. And in addition, claims for screening or assessment of mental health or substance use disorder will be included in the measurement, regardless of whether the claim includes a primary behavioral health diagnosis. The behavioral health claims will be categorized based on place of service, revenue, and service codes. Those categories are relevant for both reporting purposes and for identifying spending that would be included in a focused behavioral health investment benchmark. The other behavioral health services category is used for claims that meet the primary behavioral health diagnosis criterion, but do not have a place of service, revenue, or service code associated with any specific subcategory. And then finally, a set of national drug codes will determine whether a pharmacy claim should be included as either mental health or substance use disorder spending, independent of diagnosis. And on the next slide, we have the process map that brings together the steps for identifying behavioral health claims. And we reviewed this with you in June and wanted to revisit it today since it's central to our proposed definition. So starting with the blue box on the top left, the first step is to determine whether the claim includes a behavioral health diagnosis in the primary diagnosis field. If the primary diagnosis field does not contain a behavioral health diagnosis code, then the claim may still be considered behavioral health if it includes a service code for mental health or substance use disorder screening or assessment. And that orange box recognizes that screening for mental health and substance use disorder conditions is important for prevention and population health, regardless of the resulting diagnosis. OCA believes its measurement approach should incentivize these important services, and so if one or more of those services is on the claim, then those lines of the claim are considered behavioral health. So going back up to that first blue box, if the claim includes a behavioral health diagnosis code in the primary diagnosis field, then the next step is to categorize the service by place of service, revenue, and service codes. Any claim that clears that primary diagnosis hurdle will be considered a behavioral health claim. And this second step is to categorize the claims for analysis and later to determine what will be included in comparing spending to a focused benchmark. The separate flow, starting with the blue box on the right side of the slide, shows the process for identifying a pharmacy claim to be included in measurement. If the pharmacy claim includes a national drug code or NDC that OCA defines as behavioral health treatment, then the claim is a behavioral health claim. And all claims will be categorized as either mental health or substance use disorder spending, depending on the primary diagnosis or NDC that is on the claim. On the next slide, we see how the recommended behavioral health service subcategories, how we're recommending that those subcategories be rolled up into higher level service categories for reporting. So those categories that you see on the left would be used for reporting and also for identifying spending that would be measured against a future focused benchmark. And as we mentioned before, the other category includes claims with a primary behavioral health diagnosis, but without other identifying codes to place them into one of the defined categories. We go on to the next slide. We're shifting over to the non-claim spending module. And these are our principles for non-claims measurement. So this measurement will involve a variety of methodologies for allocating some or all of a payment to behavioral health. Non-claims payments will be classified using the expanded non-claims payments framework that we've developed with our colleagues at Friedman Healthcare, and that is being used to classify non-claims payments in OCA's total medical expense, alternative payment model, and primary care spending data collections. So the various methods for allocating non-claims payments to behavioral health include classifying payments for population health, behavioral health integration, and care management as behavioral health only when those payments are made to behavioral health providers, limiting the portion that can be attributed to behavioral health from payments for practice transformation, information technology infrastructure, and analytics, including 100% of behavioral health capitation payments, and allocating a portion of other types of capitation payments to behavioral health using a formula similar to the one adopted for allocating capitation payments in primary care. And all non-claims payments identified as behavioral health will be included in our measurement of spending. We can go on to the next slide, and these next three slides review the expanded framework subcategories that OCA is proposing to include in its non-claims behavioral health spending measurement, and the specific approaches for allocating non-claims spending in each of them. So in expanded framework category A, which is population health and practice infrastructure payments, payments for subcategories A1 through A3 would be considered behavioral health spending if and only if they're made to behavioral health providers and provider organizations. All subcategory A2 payments for primary care and behavioral health integration would be included in the behavioral health and primary care module as part of behavioral health spend. Spending in subcategories A4 and A5 would be limited to a maximum allowable amount. And OCA's recommendation is that that limit be equal to the portion of total claims and capitation payments going to behavioral health. So in other words, the amount of practice transformation and infrastructure payments attributable to behavioral health would reflect the portion of spending for behavioral health in claims and capitation payments overall. And the formula for this allocation is in the appendix of the slide deck for your reference. Category B, performance payments, would be recognized as behavioral health payments when they are made to behavioral health providers. On the next slide, we have category C, which is shared savings arrangements. And condition-related episode-based payments would be included in the measurement of behavioral health spending if the episode of care in question is behavioral health related. We're not aware of any existing or planned procedure-related episode payments for behavioral health, nor of any health plan arrangements with behavioral health practices agreeing to take on risk for total cost of care, and so those categories are not applicable. On the next slide, we will go to our final slide on non-claims payments, which is about capitation. So for behavioral health capitation, subcategory D4, 100% of those payments would be included in behavioral health spend measurement. For more general types of capitation, professional and global, and payments to integrated comprehensive systems, the behavioral health portion would be allocated using a similar formula we use for allocating capitation payments to primary care based on encounter data. So the formula for this allocation is in the appendix. And as with primary care, facility capitation payments would not have a portion allocated to behavioral health spending. And finally, payments in category E, other non-claims payments, would be limited to a maximum level using that same proportional method recommended for the infrastructure and practice transformation payments in subcategories A4 and A5. And go on to the next slide to talk about our third module, which measures spending for behavioral health and primary care. Distinctly measuring the spending for behavioral health delivered in primary care settings is intended to promote policy priorities such as the expansion of integrated care and greater attention to preventive behavioral health care. OCA proposes to measure behavioral health in primary care through its total healthcare expenditure, or THCE, data collection, and by using the Healthcare Payments Database, or HPD. This dual approach optimizes OCA's ability to understand this aspect of behavioral health spending while minimizing data submitter burden. So on the next slide, to get more specific, we can see that for its THCE data collection in 2026, which is the first year that data submitters will provide behavioral health spending data, OCA will capture a portion of behavioral health and primary care spending using existing primary care provider definitions and distinct behavioral health spending subcategories. In the longer term, over the coming year, OCA will conduct iterative analyses using the HPD to explore how to refine the methodology to include integrated behavioral health provided by behavioral health clinicians who are not part of the current primary care definition. The methodological refinements would include an expanded list of primary care provider taxonomies and perhaps additional services such as psychotherapy. And we hope that these HPD analyses will give us insight into how to bring additional legitimate integrated behavioral health spending into this module without overcounting. Go on to the next slide and see we have here a visualization of the behavioral health and primary care module. So the green box at the intersection of the two larger rectangles is this module, and the spending in that green box would be part of both total behavioral health spend and total primary care spend. And so importantly, the criteria for inclusion in the module must be such that spending in the module must independently meet the criteria for both behavioral health spending and for primary care spending. And the equation at the bottom of the slide shows that if we were to sum behavioral health and primary care as components of total medical expenditures, the behavioral health and primary care module would need to be subtracted so that it's not counted twice. Going to the next slide. And this is a little bit more about what's included in the module. So it contains both claims and non-claims spending. And the proposed initial definition for the module in the 2026 data submission is that for claims-based payments, behavioral health claims in the outpatient professional primary care subcategory would be included in the module. And this subcategory includes codes for the collaborative care model and other integrated behavioral health. In our HPD analysis of spending by subcategory that we looked at earlier, the outpatient professional primary care subcategory in total accounted for less than 2% of all behavioral health spending. For non-claims payments, payments for expanded framework category A2, which is primary care and behavioral health integration payments, will be included in the module. And I want to emphasize that services that are not included in the included in this behavioral health and primary care module would still be included as behavioral health spending as long as they meet the criteria for claims or non-claims payment that we reviewed earlier. And we can go on to the next slide. So our OCA's proposed definition and methodology for measuring behavioral health spending were posted for public comment during the month of August. And over these next few slides, I will summarize the comments we received and OCA's responses. So we can move on to the next slide. We received a total of 7 comment submissions. One was a joint comment letter submitted by 5 organizations representing consumers or specific population groups. There were comments from 3 organizations representing providers, 1 quality organization, 1 organization representing payers, and then 1 comment submission was from a labor organization representing healthcare workers. And all these comment letters are posted on the OCA website with the materials for today's meeting. So on the next slide, first we'll look at the comments that were directed at the measurement methodology. Regarding using diagnosis as the principal means of defining a behavioral health claim, 1 comment expressed support for this approach as opposed to using provider taxonomy. 3 comments addressed using only the primary diagnosis to determine whether a claim was for behavioral health, suggesting that this approach was too restrictive and that including claims with secondary behavioral health diagnoses or other ways of capturing all behavioral health services should also be considered. OCA believes that including spending from all claims with a secondary behavioral health diagnosis would significantly overcount behavioral health spending, and it would also impose additional burden on data submitters. 1 comment urged OCA to use G codes in the ICD-10 classification related to dementia in the definition, in addition to F codes, because G codes are more likely to be used in capitation arrangements. And OCA will continue to evaluate the inclusion of G codes, including consideration of those codes overlap with the relevant HEDIS measurement year 2024 value sets. When defining claims as behavioral health spending when there's no primary diagnosis, 1 commenter suggested using specific procedure and service codes in addition to the screening and assessment codes that are already part of the definition. And OCA feels that expanding the list of services that do not require a primary behavioral health diagnosis would add data submitter burden and also would increase the risk of overcounting. On the next slide, we have 1 commenter encouraged OCA to incorporate encounter data into the methodology, and encounter data is in fact used in the non-claims part of the methodology to allocate portions of capitation payments to behavioral health. 2 commenters suggested using several place of service codes to include in the definition, such as partial hospitalization, long-term care, and intensive community treatment. And we want to emphasize that OCA's measurement of behavioral health spending is not limited by place of service, and these suggested place of service codes are among those that are included in the methodology for organizing spending into specific service subcategories. 1 commenter would like to see mobile clinic services as a subcategory to encourage the provision of this type of care. The investment and payment work group discussed this issue and looked at data from the HPD, which showed minimal spending in this subcategory in the past. Also, the analyses of mobile clinic and crisis services that were of greatest interest to work group members wouldn't be possible with the data that OCA will be collecting to measure behavioral health spend. For example, work group members were interested in understanding utilization trends for mobile crisis compared to emergency department services. So OCA will look at HPD as a potential data source for these types of analyses and will continue to monitor the spending in this subcategory using the HPD. And OCA is open to including a mobile services or crisis services subcategory in the future, incorporating what it learns from HPD analyses and implementation of the measurement methodology. 2 commenters would like OCA to include Medi-Cal data in the measurement of behavioral health spending as soon as possible, emphasizing that these payments, including those made by county behavioral health plans, are important components of the overall behavioral health spending picture. OCA very much agrees and is actively working with DHCS to develop protocols for collecting spending data from both Medi-Cal managed care plans and county behavioral health plans. 1 commenter urged OCA to include paraprofessionals in the definition. Provider type is not part of OCA's definition of behavioral health claims spending, and so any services that paraprofessionals provide will be included if they meet the primary diagnosis requirement. On the next slide, then we had several comments on the specifications of the behavioral health and primary care module. In general, commenters supported the concept of the module for measurement and policy purposes. However, opinions were divided about expanding the list of primary care provider taxonomies to include some behavioral health professionals, which was part of the methodology as proposed for public comment. One commenter supported the expansion so the measurement could capture a greater amount of integrated behavioral health in primary care spending. And two other commenters opposed the taxonomy expansion because it gives rise to potential overcounting of integrated behavioral health spending and the associated impact of overcounting on the measurement of primary care spending. So OCA is sensitive to this potential for overcounting, and in response to those comments and our discussions with the investment and payment work group, OCA has updated its proposal for the module to not expand the primary care taxonomies in the short term and instead to use the HPD to analyze options for an expanded behavioral health and primary care module in the future. And so this updated approach is the approach to the module that we just reviewed a few minutes ago. Another comment on the module suggested that to avoid double counting, OCA should count simpler services such as screenings and referrals as primary care only and count more complex diagnoses and treatments as behavioral health. And OCA's response here is that these services, both the simple and the more complex ones, are counted in the module as both primary care and behavioral health, and that the creation of the module allows the spending within it to be included or excluded from primary care spend or behavioral health spend. And the design makes it straightforward to avoid double counting of the services that are included. Go to the next slide. So as you know, the board has delayed adoption of a behavioral health investment benchmark until at least summer of 2026, and none of the commenters disagreed with that decision. Two commenters explicitly supported the delay, and two urged OCA to use the time to fill data gaps to support a well-informed benchmark proposal. OCA is planning some pretty extensive analyses to support benchmark development over the coming months. One commenter expressed that the benchmark should encourage investment across the full continuum of care rather than focus on outpatient and community-based care. And OCA notes that stakeholders strongly supported an outpatient-focused benchmark as we developed our benchmark proposal earlier this year. OCA will revisit the question of the focus of the benchmark when its planned analyses are completed and will share those findings with stakeholders, including the investment and payment work group and this committee, to inform future discussions of the benchmark. And finally, several comments went beyond the specifics of OCA's proposed methodology for defining and measuring behavioral health spending. Suggestions included that OCA develop a plan and timeline for measuring out-of-plan, out-of-pocket spending, assess both spending and utilization associated with Z codes, including codes used to identify social determinants of health, document preventive and treatment services in various settings to assess access to care, measure spending against unmet needs and desired outcomes, measure cost savings associated with different care modalities, and evaluate the payment rates for non-physician behavioral health professionals. These are all important issues for understanding behavioral health spending and the state of behavioral health care in California in general, but they're outside the scope of OCA's data collection and are best addressed as supplemental analyses or research studies. And OCA will evaluate these suggestions alongside the other analyses of HPD data that it plans to conduct in the coming months. And finally, this is a timeline of the process that remains for finalizing the behavioral health measurement definition. So following today's meeting, OCA will finalize the definition and measurement methodology in October so that it can be included in the next version of OCA's data submission guide. We'll share the definition with the board in November, and it will be published in the 2026 data submission guide next spring. And throughout this time, OCA is working with DHCS and Medi-Cal managed care plans to ensure that our final definition will accurately reflect managed care plan spending. And we can move to our final slide. This wraps up our update on OCA's behavioral health work stream. And so we're very interested to hear the advisory committee's feedback for us on the behavioral health definition and measurement methodology.
Great. I've got Sumana and then Marielle. Andrew.
Oh, my goodness, this has got to be the most complicated of all the complicated pieces that we've dealt with. And I just have to thank you for, even trying to tease it out. The integrated behavioral health piece is something that, any good primary care clinician cares so much about. And when you point out that less than 2% of it is happening currently, and you heard my own struggles with trying to get a therapist onto plans. And I think that's clearly, I worked with every stakeholder I could think of, and no one had adequate suggestions. They could not get onto a lot of these plans. So the commercial plans have got to step up and enroll therapists and be willing to work on these models. And I know that, again, is outside of our purview and what you can achieve, but if we cannot create incentives for that to happen, then this wonderful model will be really, really tough to develop. I wanted also to, I know there was a technical question, and I'm so sorry, maybe I missed that, but the idea of how do you decide what's primary, very kind of limited EHR abilities to change things, or just the technical focus of this will be very hard, in actuality, without major support and funding to make it worthwhile, especially because we've combined screening and treatment, and screening turns into evaluation and treatment often enough for pediatrics, internal medicine, family medicine, and we're screening everyone, right? So every physical, there are going to be those screening codes. I just wanted to point that out. And finally, that good care is about every chronic pain and chronic disease, such as diabetes. Diagnosis has to go along with a behavioral health piece, because 70–80% of the time, if we address that, will decrease utilization when you look at emergency room. And I saw that comment about we're providing all this care in the emergency room. Well, you shouldn't have to be, And this is where APM work has helped me really home in on those people who show up because they're anxious. Just that alone could make such a difference. We need to improve integration. We need the incentives for it. And this work, if we can focus on that, we'll do this work right.
Thank you. Mario?
Yeah, thank you so much. I know that this has been quite a labor of love, and I appreciate you breaking down all of the comments that were submitted in response to this. I just want to, again, pause a little bit on the restrictions on coding for behavioral health type of conditions. Oftentimes when folks, most people who are seeking behavioral health services will go to someone who specializes in it. It's not really something that they bring up primarily in primary care, but the reason why I'm bringing that up is, when it comes to mental health screening, the idea is it should come up at any time, right? So I guess what I'm trying to comment on is, how do we continue to appropriately document it so we can submit it for data, but at the same time know that most people who need these services aren't going to get them because they don't have a diagnosis. That's a huge limiting factor. So, I really hope that we, spend some time in this break, and thank you. I'm really happy to hear that we are delaying and postponing, but I hope that we're taking this time to also consider what that means for a community when we are basing off of primary diagnoses if they're not coming in specifically for these services in the first place. So I just wanted to make sure we pause on that and focus on that in the next coming months. Thank you.
Thank you, Andrew.
Yes, we should have the data in HPD to do that analysis. So we can look at our, we have a long list of recommended analyses that we work on over the next, several months, year or so. So we can look at how to prioritize understanding the spending that is potentially lost or not lost, but is not included if we do not include secondary diagnosis. Okay.
Great, Karen.
Well, I really appreciate this work, and I think the work group process on this issue has been really great as well. So thank you for that. And I just continue to support having a benchmark that's based on the outpatient behavioral health spending to really get all the entities in our healthcare system to focus on where we really need to be doing more, investing more, creating more opportunities, more access points for consumers. So I'm glad to see that continues to be reflected in what you're proposing, even if the benchmark is delayed, which I think is fine given the complexity of this. I did want to clarify the behavioral health and primary care piece. If someone is in primary care receiving a screening or assessment for behavioral health needs, is that no longer counted as primary care and now only counted as behavioral health? I'm just trying to, can you just clarify that piece for me?
Sure, thanks for that question. It is confusing, but so that would be included as both is the answer. That it would be counted as primary care, and also in this module that we can break out and subtract from the sum of behavioral health and primary care. So it would count in both.
All right, I had another hand that was down that side. Was it Amanda? Okay, thank you.
Thank you. I heard you get paid by how often you talk, so yeah, I've been trying to.
There you go.
Yeah, no. Just echoing so many of the folks around the table who, just gratitude for the amount of work and consideration that's gone into this. As someone who started at Health Access doing a lot of mental health advocacy work, I have a deep appreciation for how broken this system is and in how much, I'll say, how much room for improvement there is in consumer access to care and just making sure that people get the appropriate level of care they need when they need it, the need to be focused on those outpatient, more upstream interventions. I did notice in the appendix, it seems like there's been, a big increase, one of the bigger increases in outpatient professional non-primary care. That's slide 126. Does that reflect increases in price, increases in utilization?
You're testing my memory of the details of the analysis, but but I believe that was majority a utilization increase. And I don't think we've yet gone into how much of that is telehealth, but that may be a substantial portion of it. But we can follow up on that.
Thank you.
Thank you. I've got Mike, then Sarah, then Katie.
So I'm going to ask another clarifying question like Karen did. So if a primary care physician sees a patient and codes a behavioral health, mental health diagnosis, that's counted?
Yes, it is counted in the module. Yeah, the behavioral health and primary care module.
Sarah.
One thing about the diagnoses,
For Medi-Cal under 21, a diagnosis isn't required to receive mental health services. And maybe I don't have the greatest understanding, but are those services still captured in either the claims or the non-claims based payments? So some of this may be relatively new related to CalAIM and it's been a few years though, that an F code diagnosis is not required, just an ICD-10. So like, for example, I'll see children for individual therapy and bill, I forgot the codes now, 90834 or something like that, with like a Z code. But I'm providing psychotherapy, mental health treatment. So if it isn't accounted for in any of the claims or non-claims based spending, that would be a huge hole, because Medi-Cal Children's Mental Health Services is a good chunk of mental health spending, I'm guessing. And also the fact that Medi-Cal beneficiaries, or I think they're now called members, of any age can receive services without a diagnosis. Well, if they have a potential mental health diagnosis not yet diagnosed. So those would be services that would happen before a diagnosis, but it would still be mental health assessment and treatment. So there's that. And someone had mentioned like incentives for mental health treatment therapists to go onto insurance plans or to be integrated into primary care. And I know I've mentioned this before. The Research Triangle Institute's 2024 study, which I think is really significant in that the findings were that one, out-of-network use is many times higher for behavioral health treatment than medical surgical treatment, even for telehealth, and that provider shortages don't explain the disparities in out-of-network utilization and reimbursement. And so that's the other thing. Office visit in-network reimbursement levels were much lower as a percentage of Medicare rates for behavioral health versus medical surgical providers. And of course, this is anecdotal, but I believe it is true that a lot of therapists operate outside of the system. I happen to not be one of them, but I feel like I'm rare in my little network. That they take cash pay or private pay because the onerous demands and headaches, and I mean, I've heard stories from people about trying to get reimbursed and the reimbursement being like way lower than what they get out of pocket or what private pay provides, and trying to, afford a living in California. Those reimbursements don't, cut it. And so that just makes me think that maybe that's something that, like, as a supplemental analysis, maybe could be looked at if health plans aren't, increasing their behavioral health spending and increasing access. What are they not doing, or what could they do to change that and actually bring in therapists, incentivize them to actually provide care within our insurance-based healthcare system. And I think there was one more. Also kind of going back to the codes, I bring up dyadic services again. It's relatively new in California. I mean, it's been a few years, although at least like where I work in an FQHC, it's new for us to be able to bill it, although they haven't figured that out yet for me. But that is true preventive early intervention care for children. Like instead of waiting for a child to have PTSD and have to treat them, have them go, get to the point where they are suffering to that degree or any other diagnosis. It's about providing mental health support that's not necessarily individual psychotherapy. For example, psychoeducation to prevent the development or worsening of behavioral health conditions, assessment, screening, and brief intervention to the parent or caregiver for the benefit of the child, screening of adverse childhood experiences, linkage to needed resources. Like an example being last week, there was a patient that came in where the parent has substance use problems. They're homeless, living in a shelter. It's a young elementary school age child. The child doesn't have necessarily any mental health condition, but that would be, if I was able to bill, that would be someone I could provide these kind of services for, and with the goal of preventing, because that child obviously is at high risk of developing a range of emotional and behavioral problems because of the high degree of stress in their life. And so even though this may make up only a small portion of what's being provided, I feel like this is one area that we should really be incentivizing. So we should be tracking it. I feel like I had something else, but I can't think of it right now. If I think of it, I'll let you know.
Thank you. Katie?
This is a comment, and I'll make it as short as possible. I work in education, and with the influx of money that has come to schools following COVID, many schools have, school districts have established robust behavioral health wellness centers with licensed social workers. I know too in my area, Monterey County, that don't currently bill Medi-Cal. And I think I mentioned this because I think this is primarily where school-aged children and adolescents are receiving behavioral health if they're on Medi-Cal, because it's such a desert for them to be able to find a therapist outside of their school system is almost impossible. And something that I'm going to be thinking about in the next year is, as funds are less robust with school districts, where are the cuts going to come? And if they do need to cut behavioral health through wellness centers, where are those families going to then continue their care? And it's just something that I'm going to be thinking about. I think all of the work that you've done over the past couple years, I really see a plan forming that makes a lot of sense. And I also see the gaps that isn't being counted, but I don't have any idea how to count it unless they are billing through Medi-Cal and you're looking at Medi-Cal. So thank you for all your work.
Thank you. Sarah, did it come back?
Okay, so the things I forgot. This is, I guess, another comment more on maybe supplemental analyses or evaluating quality. Just a thought about looking at level of care provided. So like if someone is diagnosed with major depressive disorder and they are only getting medication, that isn't the standard of care. If they're diagnosed with major depressive disorder in remission, that makes a lot of sense. But I'm thinking if there's a deeper dive that has to happen to evaluate quality, taking a look at like, oh, okay, someone's diagnosed with PTSD and they're getting 6 sessions of therapy and that's it. Like that isn't the standard of care. So really taking a look at like a deeper dive into the services being provided. I guess that would be kind of like something that the DMHC does when they do like a more targeted investigation. And then the other thing, the out-of-pocket spend, I would make an argument that probably the majority of out-of-pocket therapy spend is that people pay out of pocket is therapy that they need and that's medically necessary that they're getting because they can't get it through their health plan, either because they just can't get therapy in general or they can't get a culturally or linguistically appropriate provider. So I do think looking at that kind of private pay is important because I don't think there's a lot of therapy happening. I mean, this is just my personal opinion, but if you don't need to spend money on therapy, if you don't have to go to therapy, I don't think there's a lot of people just going to therapy for the fun of it. So I think looking at the amount of people paying out of pocket and using that to help inform decisions about what the actual spend needs to look like within the insurance industry would be helpful.
Thank you, Maria.
Just my last comments. I just want to thank all the effort that's been put into these criteria. I think that, you know, someone who works in the behavioral health space, we're definitely anticipating a greater need with all of the struggles that people are having due to immigration and so forth. Things that I just want us to consider moving forward is I don't know what utilization is going to look like with folks who may be afraid to use services because of their immigration status. So I just want us to be cautious about that, but also, you know, this artificial division between mental health and substance use disorder is just that, it's artificial, right? We know that people who have some kind of substance use disorder oftentimes experience something on the mental health end. And, you know, these are symptoms of a root cause. A lot of that has to do with lack of adequate basic resources. And that's what we're going to keep seeing. So, you know, I think that, you know, I'm glad that we're bracing ourselves, but also, you know, just really think about what this landscape is going to look like as services continue to get cut from people who are already with limited access. So thank you.
Thank you. I think we've got one more comment and then we'll wrap this item up.
I just wanted to make one more brief comment about the stats about substance use disorder treatment utilization versus mental health utilization. It was kind of, I mean, not unexpected, but still shocking to see how small the spending is for substance use disorders compared to mental health, or I don't know if that's utilization or spending, maybe those are correlated, so it doesn't matter. Because in my experience, those often are comorbid, and it also kind of reflects my experience of having difficulty getting patients connected to substance use disorder treatment and being kind of I mean, I have training in education, but I'm not a specialist by any means in substance use disorder, and having patients who have severe substance use disorders and at my current job, teenagers, and being kind of their primary substance use disorder treatment provider because of their difficulty getting adequate care. I think my personal experience kind of like aligns with what the data you have shows.
Thank you. I'll turn it back to Margaretta. I think you've got a bit more.
I think we just wanted to wrap up and say thank you all for your excellent comments. And I think, Sarah, many of the notes you brought up, we have incorporated into our thinking, especially the RTI study and how we're thinking about approaching the benchmark. And we'll note that we, you know, are looking at how we could potentially measure out of plan, you know, out of pocket, out of plan spend, and hope to bring an update back to you all sometime soon. So really appreciate all of your feedback today and all of the questions. And, you know, we'll use this information moving forward in how we potentially revise the definition that we release or we include in the data submission guide this fall and is finalized next spring.
Thank you. All right, we'll now move to public comment on this agenda item. And because this is the final agenda item, we can combine that with general public comment. If you'd like to make a comment, please step to the podium or raise your hand. We've had a couple folks with their hands raised online. I will start with Sean Kim.
Hello again, Sean Kim from CPHA. As you refine the methodology and defining the measuring of behavioral health spending in primary care setting, I urge OCA to fully recognize and integrate the critical role pharmacists play in behavioral health. Pharmacists are often the first and the last point of the contact for patients managing mental health challenges and substance use disorder, particularly in underserved rural and metropolitan communities where pharmacies are the only accessible healthcare site. Pharmacists serve as a frontline provider for medication-assisted treatment, MAT, ensuring timely access to buprenorphine, which is removed from the X waiver, and other therapies. They also can prescribe naloxone, life-saving medication, directly into the hands of the patient, families, and communities. Beyond SUD care, pharmacists administer long-acting injectable and antipsychotics, just like any other biologics, provide medication therapy management for depression and anxiety, and collaborate with the care team to improve adherence and outcomes. However, recognition is not sufficient. These services must be sustainably funded. Just as the state developed a reimbursement framework for vaccine administration, behavioral health services provided the pharmacists also require proper reimbursement model. Pharmacists cannot continue providing these services at a financial loss without risking further closures, just like 347 Rite Aid closures. To ensure the progress in both measurable and sustainable, I urge OCA to explicitly capture pharmacy-delivered MAT and naloxone in behavioral health spending definition, acknowledge pharmacies as essential care sites, and develop reimbursement framework behavioral health services in pharmacies through Medi-Cal MCOs and other commercial payers. California cannot meet the behavioral health goals without pharmacies as a fully integrated partners recognized in definition and supported as a sustainable reimbursement. Thank you.
Thank you. To the podium.
Hi, Jen Nguyen with the California Hospital Association. We submitted public comments on this issue and would like to raise a few points here for consideration today. First, we are supportive of OCA's work in promoting growth in behavioral healthcare access in the state. However, we believe that OCA should take time to evaluate and consider additional behavioral healthcare services provided to patients with primary medical diagnosis and not just those with primary behavioral health diagnosis. Without further investigation, OCA's proposed measurement methodology risks undercounting clinically appropriate behavioral health services that should be tracked and encouraged by OCA. Lastly, as OCA looks to set a behavioral health investment benchmark in the future, we encourage OCA to look across the entire continuum of care settings, including residential and inpatient care, instead of solely focusing on outpatient behavioral health care. Thank you.
Thank you. Seeing one hand raised online, Steve, go ahead.
Hi, this is Stephen Chen, Associate Dean for Clinical Affairs at the USC Mann School of Pharmacy. I also direct something called the California Right Meds Collaborative, which is a partnership between health plans, pharmacies, and FQHCs, supported by value-based payments that assign pharmacists to patients with persistently uncontrolled chronic conditions for medication management, both for physical and mental health disorders, as well as providing on-site CHW services. I just want to say that medication use for behavioral health disorders, probably no surprise, is generally suboptimal. We did a study of a big health plan that specialized in mental health. We found that in some patients were on up to 5 concurrent antipsychotics, which we know was not appropriate. We've also done studies of dosing of antidepressants in many health systems. They are often underdosed and persistently at that level. So measuring adherence is not enough for those patients. What are the reasons? Primary care providers, if they're honest, are generally uncomfortable with managing psych medications. Psychiatrists are great, very limited supply, very expensive, could be part of the reason costs are going up. Pharmacists have within our profession board-certified psychiatric pharmacists. They're well positioned to fill these gaps in suboptimal medication therapy, from dosing selection to monitoring for safety and efficacy, managing the cardiometabolic side effects from these meds. They're great team-based care. They help unhoused patients stay housed by ensuring they're mentally stable enough to be able to stay in housing. They provide treatment consults to other providers. And then the other piece I want to clarify is that we need to expand the role of pharmacists in making sure they operate optimization for both physical and mental health conditions, and we need better treatment success measures that relate to medications. NQF, CMS, and HEDIS, they don't get into the root of the issues, which again include dosing and the inappropriateness of multiple medications. Thank you.
Thank you. Looking to the podium, seeing no one at the podium, looking back online, we've got one hand raised. Jeffrey, go ahead.
Thank you. Jeff Nahiro, again, pharmacist at NutriShare, also a Sac Valley Pharmacy Association board member as well. Again, in support of all the other pharmacists that are on the call as well, I think pharmacists are well positioned to assist with the development of new treatment plans, as well as multi-drug therapy regimens for many of our patients, and be that main coordinator of care. Unlike a lot of other healthcare professions as well, pharmacists, even on the front line of the pharmacy profession, are constantly with our patients. We have the medication profiles there. Patients have a tendency, especially with behavioral health and mental health challenges, have a tendency to switch providers often. Oftentimes, pharmacists are the most consistent care providers for them, that are able to help them to ensure that there are less drug interactions in their profiles, to help keep them also more under control. They are, by asking questions too, we're also in a very unique position to assist them and help diagnose or help other folks diagnose the additional comorbidities that a patient may have. So a patient, may be bipolar or schizophrenic, and that may not have been diagnosed upon just initial screenings that you may see in a clinic. Additionally, I think you've also heard that there are many folks on this call that are part and conjoined with different pharmacy schools in California. I encourage OHCA to talk to the different pharmacy schools to see what partnerships they have in the communities where they're located. I know myself, I used to be the department chair of clinical administrative sciences and experiential education at one of the pharmacy schools, and I helped set up clinics for our pharmacists to partner with physicians to help treat patients in partnership with UC Davis. So those are other avenues that this committee can reach out to again, meet with pharmacists and help them be consultants for the general public to help improve this public health urgency that we currently have. I would just like to make one last comment regarding we are really just seeing. Oh, thank you. We are really just seeing the start of the younger generation with mental health challenges coming out of that may not have been treated when they were in during the COVID-19 pandemic. So as this population possibly or potentially gets worse, and how we have an increase in homeless population, reaching out to pharmacists would be ideal for this committee. Thank you.
Thank you. Looking to the room, seeing no one at the podium and seeing no hands raised online, that concludes public comment on that agenda item and our general public comment period, taking us to a reminder for our next advisory committee meeting on January 14th in the new year. And that concludes our meeting today. We are adjourned. Thank you.